Welcome everyone to Senior Solutions, Balance for Optimal Aging. We're getting ready to start in just a few minutes. If you are having any issues with your audio or your screen, please give us a call at 410-887-2002 and allow us to help you get set for the day. You don't want to miss a minute of this valuable training that we're having. Again, the closed captioning is in the bottom left-hand corner of your screen if you would like to activate that. And you can also pick the language that is of your preference. Once again, our number is 410-887-2002 if you need any help. Good afternoon, everyone that's joining us. Baltimore County Department of Aging is happy to host the Senior Solutions Conference this afternoon. If you're experiencing any difficulties in connecting to WebEx, please feel free to contact our office at 410-887-2002. You can also email us any issues that you're having to sponsor bcda@baltimorecounty.md.gov. To turn on captioning, please click on the icon in the bottom left-hand corner of your screen. Once you click on the icon, you can select the language of preference for captioning. For those of you that are interested in CEUs, please be sure to keep your WebEx open as our system will track active time, also your polling answers and the end of the day survey submissions. CEU hours will be given based on your direct relation to all of those items. We will be starting momentarily. I see lots of individuals jumping on the conference, and we'll give them a few minutes to get settled, and soon we'll be kicking off.
So welcome. Our mission today is very strong, as always, in strengthening lives by providing services, programs, and connections to resources. We hope to empower each of you through this conference to better serve your clients, your members, your customers. BCDA offers many options to connect with our programs and services. So please remember to share with your clients and colleagues the many ways you can remain connected with us, such as our government website page, Facebook, our Time of Your Life Digest, our community resources, the Time of Your Life TV show, and BCDA's 20 senior centers offering virtual and in-person programming. In 2023, we also designed a YouTube channel for on-demand programming and educational presentations. So for questions about our services, don't hesitate to reach us at the Maryland Access Point of Baltimore County, or MAP, at 410-887-2594. Today's conference recognizes the importance of balance for optimal aging. Maintaining good balance is always important, no matter your age. However, it becomes a bit more difficult to maintain your balance as you age. When you're young, you rarely have time to think about balance. If your core muscles stay strong, you're in good shape. But as we age, unfortunately, our ability to balance decreases. roughly 1 in 4 adults over the age of 65 reports falling each year. That's 36 million falls a year, with 3 million of them being treated in the ER. If those numbers weren't bad enough, falls are the leading cause of injury and injury death in older adults. Within our 2 days of training, we'll discuss why older adults are at greater risk, how balance connects to longevity, and how we can better prepare the older adults in our network to maintain or improve their balance. Improving physical balance is not the only aspect we'll be addressing, because we'll also discuss equity in balance in service delivery, the connection between nutrition and balance, and financial balance for caregivers over the next 2 days of training. Thank you also to our wonderful speakers for supporting today's event, along with the BCDA Communications Office for planning and supporting this training today. Before we begin, I'm going to review a few housekeeping remarks for today. CEU credits, which I understand a lot of you have signed up for. The conference offers 6.5 CEU credits for social workers for 2 days of attendance and engagement. You must, I have to say that again, remain actively connected and respond to the various poll questions in a timely manner for the entire day to receive full credit. Thus, please activate your polling box like you would your chat box to engage in our questions. Our system will track your engagement with the computer during the day and provide a report of watched minutes. Attendance will also be noted by the poll questions and evaluation at the conference conclusion. So questions during the conference, please remember, use your chat option. You may direct your question to the host so that they're not shared with the entire attendee list. You will not be able to speak throughout this program. You will be muted, so the written communication is key. Please be sure you complete your evaluation at the end of the day when it will be placed in the chat. If you need to leave early, reach out to the host in the chat for the survey. The evaluation will also support your attendance. As you've heard, if you've been on a little early, if you're having technical difficulties, please call our communications office at 410-887-2002 or email sponsor bcda@baltimorecountymd.gov for assistance. These lovely ladies were on early. They've already been helping people sign on, and so they're there in the background to give you all the support you need. As far as PowerPoints and handouts, hopefully you've seen the file transfer box on your screen while you were waiting for us to start. When you're finished downloading the materials you're interested in to your computer, just click to close that file transfer box. Again, if you're having difficulties downloading or would like our office to email the PowerPoints directly to you, call that 410-887-2002 or email sponsor bcda@baltimorecountymd.gov. I know you all want those CEU certificates, but be aware they'll be emailed to you once your full attendance of both days is verified. So now we're going to begin the exciting afternoon of training. So our keynote today is Carmel Roques, Secretary of the Maryland Department of Aging. Since taking the office, she has done incredible things to shape how we age in Maryland. She's a visionary leader dedicated to improving the lives of older adults and their families, and she's known for her multi-sector collaborative approach to planning and preparing for healthier, longer lives in Maryland. She's an accomplished healthcare executive with more than 30 years of experience leading and transforming nonprofit organizations, building strong cultures of service excellence and innovation. Her expertise includes dementia, palliative care, strategic planning, organizational development, community health, and service delivery models for older people. She served for a decade as the president and chief executive officer of the Keswick Multi-Care Center in Baltimore, a 138-year-old not-for-profit community healthcare provider. Roques serves as CEO throughout the COVID-19 pandemic, creating the emergency response infrastructure required to successfully keep residents, families, and employees safe and healthy. As CEO, she also led the creation of Keswick Community Health's WISE Camp, Well Center for Healthy Living. Before serving as CEO at Keswick, she was the Chief Operating Officer for Virginia United Methodist Homes, and prior to that, she worked for 12 years at the Episcopal Ministries to the Aging in Eldersburg, Maryland, culminating in over 3 years as the COO. Her early career roles included Director of Adult Daycare and Director of Home Care Services for Catholic Charities in Baltimore. She's proudly served on many community boards, including the Village Learning Place, the Maryland American Diabetes Association, Friends and Foundation of Howard County Library, and currently Maryland Humanities. She's also served older people and their families on the Maryland Commission on Aging, the Maryland Medicare and Medicaid Advisory Committee, the Maryland Coalition on Mental Health and Aging, Maryland Care Transformation Steering Committee, and she's also past chair of both the Maryland Philanthropy Network and Lifespan Network. She's been recognized by the Daily Record among Maryland top 100 women, top CEO, and influential leader in healthcare. She has a master's degree from the University of Chicago School of Social Service Administration and a Bachelor of Arts degree from Mills College in Oakland, California. For this session, I ask you to consider that Marylanders are living longer than ever before, and by 2030, Marylanders age 60 plus will be more than 25% of the state's population. Longevity Ready Maryland is a 10-year initiative supported by the governor that will improve Maryland's aging infrastructure across government, nonprofit, public, and private sectors to accommodate the rapidly shifting demographic. By ensuring all Marylanders have equal access to coordinated care, services, and social determinants that enable healthy longevity, we can prepare for the opportunities and challenges that lie ahead for older Marylanders and their communities. It is my pleasure to welcome my esteemed colleague this afternoon. Please welcome Secretary Roques as she presents her new initiative, Longevity Maryland, Preparing for the Opportunities Ahead. Nice to see you, Secretary.
Thank you so much, Laura, and also congratulations on your long and esteemed career and all of the wonderful work you've done over the years to support older people, their families, and care providers. And I know that you won't be going far because we will be tracking you down.
I will be nearby. Thank you so much.
So good afternoon, everyone. It is really an honor to be here with you and a pleasure to be part of Senior Solutions virtual conference hosted by the Baltimore County Department of Aging. I think of this talk as a part of an ongoing dialogue with all of you who are a community of people who share a commitment to the well-being of older people, their families, and their care providers. Like you, I have dedicated my life's work to improving the lives of these folks, and I take the role of Secretary of Department of Aging to heart as I continue this worthwhile mission. When Governor Moore asked me to serve as Secretary of Aging, and by the way, that was not on my bucket list, we had a discussion about how I viewed the work of the State Unit on Aging and what I saw as priorities. I was very frank, and some of you who know me know that I tend to be. I said Maryland was unprepared for the demographic phenomenon of longer lives and falling birth rates, and that the State Unit on Aging had not been effectively engaged in addressing the current state of our rapidly growing older population or planning for the future. And the conversation with our governor went on from there. And today that conversation includes all of you. Today, I will share with you how the Maryland Department on Aging has begun its efforts to engage and work collaboratively with multiple stakeholders across the state to ensure that Maryland is prepared to effectively address the challenges, but most importantly, to maximize the benefits and opportunities of a rapidly aging society. I hope you'll leave today with a better understanding of the role of the Department on Aging and how the department has reframed its work to fulfill its mission and values. I will also share with you our efforts to create a multi-sector plan for aging that will work to improve the aging infrastructure and what we have accomplished already to date as part of our multi-sector plan known as Longevity Ready Maryland. Finally, I'll let you know how you can be involved and stay up to date on what is happening in Maryland and to support older adults. My hope is that the conversation about longer lives that can be healthy, financially secure, socially connected, and purposeful across the full lifespan will deepen and grow and serve to inform and build the required momentum to bring about significant and positive change. My vision is now and has long been a world in which healthy, longer lives will transform human societies and individuals, and no one will ever wonder again, what are old people for? According to Nikki Ramakrishnan in his recently published book, Why We Die, there have been roughly 300,000 scientific papers on aging published over the last 10 years. More than 700 startup companies and billions of dollars invested to tackle aging. There has been an explosive growth and a corresponding media coverage, which I know you all see and get bombarded by, on longevity science, longevity medicine, longevity technology, blue zones, and longevity lifestyles, including exercise, diet, and good attitude about aging. Much of the money is focused on anti-aging efforts, and reversing the effects of aging is the goal. There is a growing awareness that longer lives impact every aspect of our society. And it is not just about the individual aging process and the population that is now over age 65, but about every aspect of our society. So there are central questions for policymakers. Who will benefit most? Who will disproportionately bear the burden of a longer life? How can we influence and plan for better outcomes than what we see today? And I would say here, one of the things that we must acknowledge is that if we keep doing the same things, we will get the same results. And we know that those results for people with longer lives have not been very good. And so it is really critical that we begin to think about and plan for what will we do differently. The National Academy of Medicine's 222 Global Roadmap for Healthy Longevity frames the conversation this way: a clear-eyed, evidence-informed view of the capabilities and vulnerabilities of older people points to the very real potential of aging societies to be, on balance, positive. It is important to recognize the substantial socioeconomic gradients that drive vast differences between advantaged and disadvantaged populations within and across our countries. Together, these observations suggest that long-lived populations are not inherently a problem for societies. Rather, the problem for societies is the barriers that systematically prevent people from reaching their later years with good health needed to thrive and continue to contribute to family and society. Similarly, the Stanford Center for Longevity calls for the new map of life. The new map of life outlines some key principles to support a society where living to be 100 years old is a norm. And some of you have heard the statistics that the 5-year-olds of today are the centenarians of tomorrow. Fully half of the 5-year-olds today can expect to live to be 100. It will be the norm. The Stanford Center for Longevity outlines a new way of thinking about everything: education, parenthood, careers during youth, middle adulthood, and our later years of life. So I'm not going to go into each of these components in the new map. You see it here on the slide, but I want to highlight a couple. The new map emphasizes a shift from a deficit mindset around aging, from one that focuses on losses to one that focuses on economic and social contributions of older people. The new map also points out that healthy longevity requires investments in public health at every life stage, and that health span, not so much lifespan, should be the metric for determining how, when, and where to invest. In other words, we need to address health disparities for those communities affected by poverty, discrimination, and environmental damage. The new map of life suggests working more years, but with more flexibility in the workplace, such as paid and unpaid intervals for caregiving, health needs, lifelong learning, and other transitions to be expected over a century-long life. I highly recommend, if you have not already, you explore the new map of life and the many routes and intersections suggested by the Stanford Center on Longevity to meet the 100-year lifespan. To be longevity ready, we must begin to plan and begin to build for a different society. And this, of course, is not only a government role, but it takes all sectors: government, business, academia, and philanthropy. So, what are we at the State Unit on Aging doing to make Maryland longevity ready? First, it's important, I think, that everyone understand how the Department of Aging fits into the state and federal government structure, because it informs the role we play and the ways we can best influence addressing both the current status of older Marylanders, their families and care providers, and those in the future. The slide that you'll see next explains how the Older Americans Act was put in place in 1965, becoming the first federal level initiative aimed at providing comprehensive services for older adults. Some of you may recognize that 1965 was not that long ago, and for our country to only then to have begun to systematically address older Americans is pretty much telling about how we position the well-being of older people in our society. This act created the National Aging Network, which is comprised of the Administration for Community Living on the federal level, state units on aging at the state level, and of course, very importantly, the area agencies on aging at the local level. In Maryland, our first state unit on aging, the Maryland Department on Aging, was established in 1975. It wasn't until 1998 that Maryland Department on Aging became an official cabinet level agency. So it was in 1998 that longevity, longer lives, and the people who were living longer lives became of cabinet level importance in Maryland. Using the Older Americans Act, the Maryland Department of Aging is directed by statute to serve older adults and those with disabilities, their families and caregivers, by establishing priorities to meet their needs, by evaluating services to determine if our programs are meeting those needs, and most importantly, to plan and advocate for older adults, to review and formulate policy, and to make recommendations to our governor. We're also tasked with receiving and distributing, monitoring and reporting on federal funding and state funding to the area agencies on aging. Unlike in some states, the Maryland Department of Aging is a separate cabinet level agency. We are not part of another agency such as Health and Human Services or the Medicaid unit, and we are not required to receive and administer Medicaid funds. I raise this because there are many, many things that happen in our sister agency, the Health Department, who we collaborate with as effectively as possible, that are actually in the role responsibilities of the Health Department. And so it's incumbent upon us to find ways that we can leverage our resources collaboratively and collectively to better serve older people. The 19 local area agencies are also organized differently in each county or a group of counties, but all are part of the local county government or not-for-profits that work with the local county governments. And they are all established by the Maryland Department on Aging. So our local area I can say this, our local area agencies on aging are our boots on the ground. They are the ones that actually provide the direct services that are so greatly needed by our older population. And they are the ones that must inform the Maryland Department on Aging about what needs to come next, because they are the ones with the closest relationship with the older population. So we must prepare because we are living longer. According to Andrew Scott in his latest book, and I recommend it, The Longevity Imperative, How to Build a Healthier and More Productive Society to Support Our Longer Lives, the first longevity revolution has already occurred, which is that we are living longer lives. This is not something that we need to make happen. It's already occurring. And the second longevity revolution is now. It is the one we are engaged in. And that revolution is to begin the process to respond to longer lives by changing how we actually live. So, some of the greatest human achievements in our past 150 years have been extending global life expectancy from 30 years in 1870 to 73 years currently. And I raised those numbers simply to have you understand that longer lived populations are a recent phenomenon, but they are a massive global demographic phenomenon. And longer lives are not only becoming true across the globe, but they are lengthening. So it isn't just that we now are living longer, but we're living even longer than we did before. By 2034, people 65 plus are expected to outnumber those 18 or younger for the first time in history. So we see we have a shifting profile to our demographic. But there are also very great differences in how long and, more importantly, how well we live. And a lot of this depends on social determinants, or really what your zip code is, where you actually live. Some of the social determinants that affect older people and their families include poverty. And 9% of the people over age 60 in Maryland live below the poverty level. And that means they are living on an annual income of less than $13,000. Housing, employment, and caregiving are also key social determinants of health for older adults. And you all know that Maryland currently has a housing crisis, and it does not just impact older people. It impacts all Marylanders, but it does have a significant impact on older people who are unable to pay their rent or do not have another place to relocate to in their later years that is a sustainable housing solution for them. We know that the fastest cohort of unhoused people in Maryland are older Marylanders, and that is something that we are very concerned about. We know that caregiving is a significant issue for Marylanders of every age, and that over 360 million hours of unpaid care every year is provided in Maryland. It comes to about $8.1 billion in care. And we recognize that family care at every phase of life has an outsized impact on societal and personal health and well-being. One of the things we say in the department is that family care is all care, and that we don't just have caregivers for late in life, but that family care occurs across the life course. In each case, the data shows us that as a state and a country, we are not well prepared for the challenges, and let me stress here, opportunities of a rapidly aging society. The data shows the inequities continue to deepen across the life course, unless we do something to change that. Our healthcare models, Social Security, Medicare, Medicaid, the fragmented and increasingly profit-driven medical care delivery system are all stressed because they are not created for the current demographic phenomenon. Last century policies, practices, programs, services, and an ageist mindset need to be addressed if we are going to break the cycle and transform individuals, systems, and societies to meet the needs of today's older population. We need to plan and build for a future of healthy longevity. So what is possible? And this is my favorite part. And it is what I love about being the Secretary of Aging. I'm an optimistic person by nature. I'm a joyful older person by nature. And so I like to think about what is it we can do to support the growth of a population of older Marylanders who are healthy and vibrant well into late life. What is Maryland doing well? And what are the opportunities for improvement? What do we need to consider over the next 10 years to ensure aging Marylanders are healthy, financially secure, socially connected, and purposeful? I recognize the level of complexity in addressing longevity and the barriers that systematically prevent people from reaching their later years in good health. We must make informed, data-driven, evidence-based recommendations for change. And this brings us to the priority for Maryland Department on Aging and the state. Planning and policy work using the Center for Healthcare Strategies multi-sector planning model. So what is a multi-sector plan? You see on the slide that its core tenets include transparency, inclusion, and person-centeredness. The plan is for aging using a cross-sector, state-led planning roadmap that will transform the infrastructure and coordination of services for older adults, people with disabilities, and their caregivers. The plan is a tool, and I repeat that, the plan is a tool to connect the public, private, and independent sectors in modernizing and creating system-based solutions that touch all the major areas of aging life experience, including health, human services, housing, transportation, consumer affairs, employment, and income security. The Center for Healthcare Strategies provides a key building blocks and guidance in the development and the implementation of a plan. They have a model that they share extensively with states that are engaging in this process. And Maryland is not alone in engaging in this process. At this point, there are as many as 24 states that are looking at this model to help them change the way people age in their states for better outcomes. We joined a learning collaborative last year, and we also have expert guidance, both from the collaborative, but also in talking to our sister states who are engaged in this process. The Maryland Department on Aging is committed to providing ongoing transparency and accountability for this plan, and we're doing that with an interactive aging dashboard. So this dashboard will give a clear and concise overview of aging population demographics, community profiles, and have a searchable tool in layman's terms that can be used. The dashboard will allow everyone, community members, providers, policymakers, government employees, everyone, to explore core data sets in the context of becoming a longevity-ready state. And we are working on this right now and have been for some months, and you will be getting information as we move forward. And we actually launched the dashboard and get feedback on how that is working for everybody. Centering the well-being of older people, their families, and caregivers across all of government is a commitment Governor Moore and his administration has made by signing an executive order implementing Longevity Ready Maryland. I'm proud to say that the very first executive order signed by Governor Wes Moore this year was to develop Maryland's multi-sector plan for aging, which we call Longevity Ready Maryland, or sometimes you'll see the LRM initials. The executive order directs our department to develop a plan that will coordinate and build upon existing efforts across state agencies, private and philanthropic sectors, and other stakeholders to tackle real-life challenges throughout the life course, including access to employment opportunities, a robust care workforce, adequate caregiver support, and equitable health care across the lifespan. The Longevity Ready Maryland, through Longevity Ready Maryland, our department can leverage to the fullest advantage our statutory role, which is why I shared with you in the beginning. This is what the department is accountable for doing. Our statutory role, which is planning, policy, legislation, and advocacy. And we are now much better positioned to exert influence across all of Maryland government to address those changes necessary for healthy, longer lives. And right now, we actually have some of our staff engaged in bill signing, because I'll talk to you about it a little bit in the presentation, some of the work we've begun already to become better prepared. So our EPIC goals for Longevity Ready Maryland are building a longevity ecosystem, promoting economic opportunity, preparing Marylanders to afford longevity, and optimize health, wellness, and mobility. Through LRM, we want to build a longevity ecosystem. That's just a fancy way of saying everybody included in the work that connects a network of organizations, businesses, government agency, healthcare providers, researchers, and key stakeholders to work collaboratively to enhance the quality of life for older Marylanders. We have an incredible opportunity in this current administration to work collaboratively, because this is something our governor and our administration believes is the foundation of being able to change outcomes, and that's working together. We want to promote economic opportunity for an age-inclusive workforce through multi-generational employment and consumer participation. We want to prepare Marylanders to afford longevity through improved access to affordable housing, healthcare, and retirement planning. And we want to optimize health, wellness, and mobility for Marylanders of all ages through investments in nutrition, health literacy, outdoor spaces, public health, and transportation infrastructure. This is our Longevity Ready Maryland kind of one-page flyer, and you can scan the URL code to see what the details are on this. This aligns with Governor Moore's directive for cross-sector collaboration and sharing resources to build a more just and equitable society. As we move through the LRM process, using our longevity ready framing and keeping in mind that we have statutory requirements under the Older Americans Act, we are happy to say that the work is well underway. You can start by downloading this information flyer with a summary of the program. Securing an executive order was the first step. And this is important because it now means that this work is formally recognized as part of the work of our state government. It means that we are fully invested and fully committed to the process, and it will require checks and balances over the next 10 years. So we are only 6 months in, but we have started to take action through planning, policy, legislating, advocacy, and cross-sector collaborations. The planning began before the executive order was even signed. In fact, it started before I entered office, as I knew longer lives meant we needed better planning. Part of our planning process includes developing work groups that will come together to make recommendations. We are also setting up town halls to get input from Marylanders in all walks of life. And we have actively participated. Our staff has been actively engaged in developing the state Health Plan and the Governor's Workforce Development Plan. And I raise this so you'll understand that this is the way the voice for older people gets embedded in the work of government. MDOA worked on or supported legislation during 2024 legislative session that directly impacts older people, their families, and caregivers. We have been present, we have made connections, we have formed relationships and promoted the governor's initiatives and have achieved several quick wins, including a bill that will create a program to reimburse informal caregivers for expenses, and a bill that promotes statewide support of the Village Movement. And the Village Movement is a grassroots movement. It is a model that exists across the country and is active here in Maryland that brings together older people and other members of their local community to find ways to keep older people socially connected, purposeful, and healthy in their local community. It is part of our overarching strategy for supporting older people living in community. Our department supported significant legislation introduced by the Department of Housing and Community Development, the Department of Labor, and the Department of Disabilities, as well as the governor's housing package and privately led bills to improve job quality for home care workers and deliver one-time common sense relief to the assisted living sector, particularly small providers from the burdensome state requirements. I can tell you a little bit about some of those bills, but I don't want to go into too much detail because I don't want to run out of time to hear from you as we chat. I'm going to go on to our advocacy accomplishments, and I'll go back to specifics on bills if we have time at the end of the session. Last year, MDO, Maryland Department on Aging, awarded more than $500,000 in grant funding to nonprofit and local government organizations to support aging in place and healthy aging efforts, and to support people with dementia and their caregivers. We are currently seeking applications for more funding this year to support aging in place efforts. And so there is an opportunity for organizations to apply in this round of grants. Maryland Department on Aging leads the quality of care in nursing homes and assisted living committee, and I chair that. And this committee is engaged with the work of the Moving Forward Coalition. If you aren't familiar with that, I suggest that you just go to movingforwardcoalition.org to look at their work. The work focuses on nursing home financing, ownership, the physical environment. And one of the things we were able to do this year with a report from the Center for Innovation on the greenhouse model and pioneer workforce, we were able to share with that committee best practices for developing nursing homes. One of the things you should know in Maryland is that we have a very high proportion of nursing homes that have 3 and 4 bedrooms, and they're disproportionately located in impoverished communities and communities of color. And we believe that this is something that must be addressed if we are going to have a more just and equitable society and leave no one behind. Maryland Department on Aging is funding a program with the Mental Health Association of Maryland that provides skills and communications training for free to professionals who care for older adults in a variety of settings. And one of the things we were really focused on with that work is to not just be talking to ourselves, the Aging Services Network, all the time, but to reach out more broadly to ensure that people in all walks of life who engage with older adults are better prepared to communicate effectively and serve those individuals. We also have just launched, and we just put out a press release on this, a program with the National Center to Reframe Aging. So this is an evidence-based program. It comes from the American Gerontological Association, and the intent of this program is to activate and facilitate the ongoing conversation in the state of Maryland about ageism and the ways in which we practice, including the Aging Services Network itself, the way some of our practices, policies, and ways that we engage actually are framed in an ageist way. And we want to be able to begin to understand this better and have conversation and dialogue that creates more inclusive communities. And this work is not something that's one and done. This is some foundational work that we're engaged with the Reframe Aging on in Maryland to really, I think, to help frame the way we want Longevity Ready Maryland to be going about its work. We have many cross-sector collaborations going, and we have many partners who are listed on this slide that we work with. So we're working with the Department of Planning and the Department of Health and the Department of Disabilities to launch a longevity index on our dashboard. And this will serve as a trusted resource for collecting and sharing emerging data and research-based findings that will help to guide policy making, budget allocation, and program development that enhances the lives of older people. We are proud to join the Department of Health and Department of Disabilities and the Department of Housing and Community Development in receiving a technical assistance grant from the U.S. Department of Health and Human Services and the U.S. Department of Housing and Urban Development. And with that Housing and Service Partnership Accelerator, we will be working to help reduce risk of becoming unhoused or homelessness for older adults and avoidable high-cost services such as emergency room visits and institutional care for Medicaid beneficiaries. We're working with the Department of Health and the Maryland Information Network to increase the capacity of existing state-funded long-term services and supports to improve our No Wrong Door Maryland access point with a technical assistance grant through the National Association of Advancing States. And most recently, Maryland received $7 million of funding from HUD to help transform communities by renovating older housing, preserving affordable housing, and improving the health of children and families in these communities. Maryland Department on Aging will be working closely with the Maryland Department of Housing and Community Development on their project, which we helped sponsor, which is to support the implementation of the evidence-based capable model in Garrett County, Southern Maryland, and the Lower Shore through the Aging and Disability Network. This model helps older people improve their health and well-being at home, and we are very excited about the opportunity to partner across sectors to sustain and grow this model statewide. The capable model, by the way, was actually created here in Maryland by a Hopkins nurse who now serves as the dean of the Hopkins School of Nursing. There were also other awardees, and we are very proud to give a shout out to Howard County, the City of Cambridge, and Johns Hopkins University, who are also awarded HUD grants. So it's been wonderful to watch these partnerships and collaborations develop and grow over the past 2 years, and I'm confident we will see more of this work in the years to come. But it is not just government agencies, private companies, and nonprofit organizations that need to be excited about the future of aging. Individuals are also making an impact and are enthusiastic about Longevity Ready Maryland. So now I want to lift up and Longevity Ready Maryland Epic Innovate development of villages by creating an economy of scale approach in the organizational operations and development. Because its hub and spokes model recently received funding from the Maryland legislature, and we were very proud to be part of that, as an important pilot project. And I want to personally thank her for her work to support older adults in underserved areas. So you're probably wondering, as I'm wrapping up here, how can you be involved? You can learn more about all of these initiatives at our website, aging.maryland.gov, and you can stay up to date on Longevity Ready Maryland at lrm.maryland.gov. Keep in mind, this is a 10-year plan that we are working on, and we are about 6 months in. To get updates on progress and learn about ways you can participate, sign up for our newsletters. We have a monthly MDOA newsletter, and we have launched a mid-month Longevity Ready Maryland Reach newsletter for stakeholders. Some other ways to get involved, including joining an advisory group if you are asked, participating in listening sessions if they come to your town, or come to a town hall, and supporting legislative actions in the future that benefit older adults. So in closing, I hope that you have learned that Longevity Ready Maryland is the work of the Department of Aging, caring for older people today and preparing for older people tomorrow. The narrative about rising numbers of older people and decline in the numbers of younger people, or the age structure of our society, is not doom and gloom. It is an opportunity for all of us to change how we age. And that is the second longevity revolution. The lens of longevity readily supports working toward quality of life for individuals as well as systems change. And on that note, I'm going to say thank you very much for letting me be here. And I'm not entirely sure how we want to handle the chat, but I'm happy to answer questions and engage around that.
Well, thank you, Secretary, for a wonderful presentation of Longevity Maryland. I have received several questions. If it's okay, I'll just pass them along to you one at a time, and we'll work through. First of which is, how does the Department of Aging plan to motivate neighborhoods to create and support the village movement?
So we are very actively involved with this model that has recently been put in place by the state legislature that will help communities that are maybe don't have a village or don't have enough of the infrastructure in place to begin to develop a village. The model that's being put in place that we'll be working on in the coming 3 years actually, it is to go into those communities and help identify what the resources are, but also what the needs are, and then to have those emerging villages be able to be part of a hub that can help with sort of the administrative, legal, logistical aspects of setting up a village. But, you know, villages really are about knowing your neighbor. And no one can force you to know your neighbor. But I think with this model that is coming forward, there will be activity in neighborhoods that help begin to get people together and talking about this. So we'll put out additional resources so people can kind of figure out how to connect. If there isn't a village in your neighborhood or you're interested in the village model, to make sure you can connect directly with the folks that are going to be working on that.
Thank you. I've gotten a couple supplementary questions to that. You know, in the village concept, will the program assist with cleaning homes or helping with grocery shopping for seniors, or would it provide, you know, supervision for seniors that can't be left alone when the caregiver is out for work or carrying an assignment? Are all of that part of the planning stages in each area?
It Each village makes determinations on what their engagement will look like with their local community and what services will be provided. So it really is, they're unique to the community they're serving and to the resources that are available. One of the things that I'm happy about is that as we have begun the work of really promoting this model in Maryland, it does help the area agencies on aging and the other providers in the provider network. It provides a pathway to get them hooked up to older people who may not be accessing what's actually already available to them. And so it's a way of creating a closer connection between the formal services that are available and the informal network of services and community members who are available. But it's very individual to each village.
Are there one or two model villages that you would hold up as an example to everyone to do a little research on to learn more about?
So I think what I will do is ask Barbara to possibly put some of that in the chat. I really don't want to be singling out any particular village. You also might want to just connect with our Epic Innovator for this month. And we put, I think her contact information, I think was on the slide we did for her. But if not, we can put her contact information. She's a great person for you to contact to know more. I see Barbara put some stuff in the chat. Okay.
She did, and I have another last comment about the villages, that if someone's a nurse practitioner, how can they be of help in the villages as a provider? Just would connect in their local community. Is that what you would recommend?
I think that's the way to do it. And, you know, just as an aside, there is a community nursing model that's being explored. That stay tuned as we learn more about that. The Department on Aging isn't the sponsor of that, but we've been engaged with the folks that are trying to sort that out and figure out how to deliver something like that.
Excellent. And another question that has come in is, will there be assistance for undocumented immigrants in the plan?
They are included in the plan, and I will say this about planning. So the Department on Aging is required, as are our local area agencies on aging, to produce a plan, a state plan every 4 years. And that plan very specifically has guidance that comes from the Older Americans Act. And the guidance directs us to focus resources and to learn about and know about and be informed about special communities. And that would include undocumented workers. And there is work that goes on right now. We work with some of the state legislators on this. Issues related to better being able to serve folks that live in our country, work in our country, contribute to their neighborhoods, and are undocumented. And so there will be reference in our state plan to special populations such as undocumented workers. And Longevity Ready Maryland. So what I'm saying is that, yes, indeed, the plan will, the long-range 10-year multi-sector plan, longevity plan, and the 4-year state unit plan will reference what we think of as special communities. And undocumented persons who live and contribute to our social well-being and our society will definitely be considered in that. And I think that's what the specific question was about. And then I went on to explain that the model, multi-sector model, is the planning model we use, both for our state 4-year plan and our long-range 10-year plan. So multi-sector planning is a planning model. Longevity Ready Maryland is what we've named all the work that we do. And the focus for our work as a state unit on aging. And I'm talking about this in this way a little bit more because I want, as we're engaging across multiple stakeholders, I want everyone to understand what the focus of the work is and the way that we're going about it. So thank you for letting me add that on.
Excellent. We're going to go ahead and move on to a little bit different topic. That is there legislation, or have you advocated for legislation to help RSAs to hire persons with federal ID numbers instead of social security numbers? That it's hard finding folks to work, and those that want to work are immigrants. And what can we do for that situation?
I have not been directly involved in legislation about that. There are some other there's other legislation that we did participate in this year to try to improve the status of home care workers. We can get back to you about that if you're interested, because I do know that there has been interest and movement around that. So we can figure out who to connect you to on that.
And there does seem to be a large amount of interest in regard to the advocacy that you said you've been doing for nursing home and long-term care facilities. Is there any plan or policy put in place to regulate or provide better services in nursing homes that it seems like many are hearing of poor care throughout their networks?
So the nursing home sector is highly regulated by the federal and the state government. The state government through the Office of Healthcare Quality of the Health Department. And there is a lot of work that's been done at the federal level post-COVID to address the many things that impact quality of life in nursing homes. I would urge you to go to the movingforward.org website and look at all that's been worked on over the last 2 years. There are multiple areas where there's advocacy going on. The Maryland, the most recent thing that's happening in Maryland that impacts nursing homes and community-based service providers, home care providers, is the mandate from the federal government that 80% of Medicare and Medicaid funds going to those organizations be directed toward salaries for staff. And that will roll out over the next couple of years, but that's a massive undertaking, and it is also a very significant piece of legislation. So that just was announced. The other thing that's happening in Maryland is, of course, our assisted living regulations are open for public comment, and I would urge you all to look at that. Much of what needs to be done in to improve care in nursing homes and assisted livings is well beyond regulations and enforcement. And that's why I urge you to look into the recommendations the federal government made following COVID, and then how that has been played out in the Moving Forward Coalition advocacy work.
Adding to that, Diane is wondering, does that also, the guidelines and policy, include GNA staff?
All of the regulations? Okay.
I guess the improvements that you're talking about.
All of that, there's a huge focus on improving the status of frontline staff, and this directing payment toward salaries is a big part of that, but also improving working conditions and improving opportunities for advancement and ongoing training, education, etc. So it's the approaches are very comprehensive. Right now, as you know, in Maryland, all of that's highly regulated. So there are already regulations and standards in place about CNAs, GNAs, that's the frontline staff, nurses. So you can also, I'm not sure, maybe we can figure out how to make sure you can take a look at what the federal press release says about the focusing the dollars that come in from Medicare and Medicaid toward salaries for staff.
All right, thank you. I know that the Maryland Department of Aging was very involved in advocating during the legislative session that just concluded. Could you give maybe 3 of your priority that you wanted to see go through the legislation?
Yeah, so we were really happy that Senate Bill 202, which is the Caregiver grant, that passed. And in crossover, there was a lot of support and conversation. Delegate Shetty and Maryland Department on Aging and AARP, Developmental Disabilities Coalition, lots of people were involved in getting that passed. The Senate Bill 197, House Bill 39 was a bill to improve job quality for home care workers, and to part of that was to make sure that home care workers are actually being categorized as full-time employees, if in fact they are full-time employees, and getting the benefits that they're entitled to. And then, of course, the Village Pilot Program, which I referred to, Delegate Wolk and Senator Kelly sponsored, and that's a 3-year program with some funding that will promote the statewide village. And then we worked a little bit on a bill that would help provide more information and guidance to older adults about earned income tax credit. And we'll be doing some additional training with the AAA and the MAP network on that. And then we did some work with the continuing care retirement bills that were submitted that really have to do with regulating licensing from a financial perspective, but much more importantly, the role that we play, it is the only regulatory role that we play as a state agency, actually, is in the regulation overseeing continuing care retirement communities. And we were very involved in the change of ownership, the threshold around entities wanting to come into Maryland to buy continuing care retirement communities, the threshold of ownership guidelines for that. There's a lot of work happening at the federal level that I'm sure will begin to come into the Maryland, the state of Maryland, just around, who can own and who can buy a nursing home in Maryland and operate it. And so I'm sure there'll be more to come on that. So that's the nursing home acquisition transparency bill that we were a part of sponsoring. So those are a few. And also there was a SNAP bill. So for those of you who are interested, House Bill 666, SNAP supplement, lowered the minimum age. House Bill 666, SNAP supplement, it was a compromise that was reached, and Delegate Shetty and Appropriations Chair Delegate Barnes found the funds to be able to increase the SNAP supplement and to lower the minimum age of eligibility from 62 to 60. So they added $10 a month to the supplement, and they lowered the eligibility age, which will help many people in Maryland, but specifically older people.
Thank you. Many were interested in that information. Another question that's come in is, what do you think is your greatest accomplishment since you've taken over at the Maryland Department of Aging?
Well, I wouldn't say it's accomplished yet. I would say the thing that I am the most focused on is making sure that there is a broad understanding and support for Marylanders who are living longer lives now, and for those that are becoming older Marylanders now. And that includes, all of the young people and the middle life people and the young old and the old and those who have reached the great age of 100. So my focus is to, as I told the committee that approved my appointment, I want to center across all of what we do in government in Maryland, the well-being of older people, their families, and their caregivers. And I think launching the Longevity Ready Maryland initiative and having that become part of our state government through an executive order was a really great first step and a great accomplishment.
Excellent, excellent. Another question is, where do you think there are weaknesses in the state system in supporting caregivers?
In the state system, well, I think, and there is a council on caregiving, and Barb, I don't know if you know the URL or the way to hook people up to that. So I don't think it's just that our state government or our state system has flaws around caregiving. This is a societal issue. In our society, we have historically not elevated caregiving at any time in the life course. And one of the things you see happening in this administration, which I think is significant and may not seem like it's directly related to caregivers of who are themselves older adults or caregiving for an older adult, but the fact that we had legislation proposed to improve the availability of childcare in Maryland is a huge step, because what it begins to introduce, and this is a longevity frame and issue, families who don't have care for their children can't go about their daily lives contributing in the ways they want to. And frequently, people who have children also have elders that they're responsible for. And so it's a great sort of first step. I think it kind of announces that caregiving across the life course is something that this administration, and certainly the Department on Aging, is going to focus on. And there are going to be multiple ways that people who care for older people will find themselves supported. And that's work we are focusing on at the department. It is one of our key focus areas.
Excellent. And my last question that I've received, and if anyone has any others, please feel free to place them in the chat. But, how many people would you like to see involved in the discussion of Longevity Maryland?
1.7 who are over the age of 60, and then all of their children and grandchildren. I think this is a conversation that needs to occur at multiple levels across the state. The smaller answer to that is we're hoping, I haven't actually set a specific number with our Longevity Ready Maryland coordinator, but we're hoping that through regional town halls and through the framework of having advisory groups and work groups, that we will really reach a significant number of people. So we'll be, because we're doing this work right now, in the coming month or so, we'll actually be publishing on our, I'm not sure if it's going to be on the LRM page or where, the stakeholder advisory group, the work groups, and then as we develop the actual time frame for the various town halls, those will start to show up too. So I'm hoping that we're going to have a very broad net. And in other states who have done this, I think I was on a call, I'm forgetting which of the states was telling me that just through their the longevity, the multi-sector planning process, the very formal stakeholder engagement for the planning process, they'd reached over 200 people just for the planning part. So, you know, I'm not real sure what to say. I just know my goal is that I want everybody knowing about it, talking about it, thinking about it. I would like it to be a conversation at the kitchen table.
Well, you've certainly inspired our participants today. They had one last question. What other states are doing something similar that they could look into so they can bring some good knowledge to the table as they join you?
So I think the best way for folks to do that is to go to the website for the Center for Healthcare Strategy. And I think it's a .org. And the other thing you can do is if you just Google Master Plan for Aging or Multi-Sector Plan for Aging, it'll come up with a list of the states. And Barb's putting that in right now into the chat. So that's the best way to find out. We've been talking a lot to Pennsylvania, New York, California, Tennessee. There's an ongoing conversation that happens among us who are working on this. There are a couple of plans that are already launched and many states that are in the process.
Well, excellent. Thank you so much for sharing your time and energy with us today. We appreciate it, you being with us on Senior Solutions.
Well, thank you.
And I also want to thank your colleague, Barbara, for all of her assistance in organizing this session.
Thank you, Barbara.
All right, everyone, we're going to take a quick break. If we could be back to our computers by 1:40, answer a few emails, get a drink, and be back. We will be talking about considering a financial caregiver, know the options so you can advise your clients. Once again, we'll be back at 1:40. The United States has the greatest number of seniors who's age 60 and older living alone, or the new term solo aging, than in any other area of the world, according to the Pew Research Center. 27% of adults over the age of 60 compared to an average of 16% in 130 other countries that were studied. Solo agers are a growing group, with more never married, unpartnered, and childless adults in the population, and because adults with children may effectively be solo if their adult children live far away, or they have a child with a disability who can't care for them, or they are estranged, more aging adults are looking elsewhere for support. Preparing for life's later stages means tackling issues such as finances and estate planning, healthcare, and future housing needs, as well as anticipating health decline and creating end-of-life directives. Today, our next speaker, Lisa Weintraub Schifferle, Senior Policy Analyst, Office for Older Americans, Consumer Financial Protection Bureau, will lead us on an exploration of resources financial caregiving, including the managing someone else's money and considering a financial caregiver. Know your options. The CFPB will share tips and tools to share the informal and formal caregivers, factors to consider when choosing a financial caregiver, and how to manage guardianship, power of attorney, trusted contacts, and more. It is my pleasure to turn the screen over to Lisa at this time. Welcome, Lisa.
Thank you so much, and thanks to the Baltimore County Department of Aging for inviting me here today. My name is Lisa Schifferle, and I'm a Senior Policy Analyst in the CFPB's Office for Older Americans. And as you just heard, today we're going to talk about financial caregiving. And specifically, we'll look at what are the options when someone becomes unable to manage their own finances. So this is information that we hope will help you in your work as case managers and social workers. It may also help you in your personal life with your family's finances and thus give you better ability to focus on your work as a case manager. So think about, maybe you notice a client who's starting to need help managing their finances, or maybe you know one who's planning ahead in case they need financial caregiving help in the future, which most of us will, even though we don't like to think about it. So whatever your background or angle is on the issue, we know that caregiving is challenging and important work, and we're hoping that these resources that I share today will help you and your clients and your loved ones to help people in your community. So before I begin, on the next slide, I have to give you this disclaimer, which is just that anything I say is my own opinion and does not necessarily reflect the opinion of the CFPB. So now let me start by telling you a little bit about the CFPB's Office for Older Americans. On the next slide, you'll see some information about the office that I work in. If you're not familiar with the CFPB, we are a relatively new federal government agency created about 12 years ago. And we are designed to help make sure that banks and lenders treat everyone fairly. So if you know someone who's having a problem with their credit card company, with a car loan or a home loan, then the CFPB is a place that they can turn to for help. And in the Office for Older Americans, we specifically look at research, policy, and education to help protect older consumers from financial harm and to help people make good financial decisions as they grow older. So you can learn more about our office at consumerfinance.gov/olderamericans. But I'm going to focus today on our financial caregiving resources. I just wanted to let you all know about a new resource called Considering a Financial Caregiver. And this is designed for people early in the caregiving process. So maybe you have a client or someone you know who's just starting to notice that they need help with managing their finances, or maybe you're planning ahead for your own financial future. So this will go through available options that will help you choose what works best for that particular situation or your client situation. It covers informal caregiving options that we'll go over today, like convenience accounts or adding a trusted contact. It also covers formal caregiving options like power of attorney, guardian, trustee, or government fiduciary. And finally, it gives you a list of questions that you can use to help consider who's the best person to choose as a financial caregiver. So I'm going to go through each of that right now. On this slide, you see information about informal caregiving options. They include a conversation partner, a trusted contact person, and convenience accounts. These are all informal caregiving options that allow someone to help on an as-needed basis. These are earlier in the process usually. So a conversation partner, you'll see on the next slide, this is basically just when you give a trusted relative, friend, or professional an overview of your finances. You can share as much or as little as you want, and you're not giving up any control. For example, someone might ask their broker or banker to send a copy of statements to their adult child or their accountant, or ask a trusted friend or relative to join them when they visit the bank or financial institution. Or you could, for instance, let a family member know what accounts you do have so that if you do suddenly need help managing your finances, they know where to go and where to look in order to help you. Of course, this is critically important to pick a trusted person to give this information to, and we'll go over how to do that in a little bit. But first, let me tell you about some of the other informal caregiving options, including a trusted contact person. This is something that you can name if you have a brokerage or investment account, and it allows the financial institution to contact the trusted person if they think that the account holder is being exploited financially or scammed. So the thing to know about this is that trusted contacts do not have access to your money. They only get notified if the financial institution sees signs of financial exploitation. So a lot of people like this because they know the person doesn't have access to their money, but it still adds a layer of protection. For example, if I named my brother as my trusted contact person and I suddenly started wiring $20,000 overseas to a place I'd never wired it, then the financial institution should contact him and say, hey, check in on your sister. So that's how the trusted contacts work. They're available now on all brokerage accounts, and some other financial institutions are starting to offer them as well. On the next slide, you'll see a convenience account. This names someone to help you deposit or withdraw money and write checks. So if there's somebody who needs that next level of help, it's not enough just to have an extra set of eyes on things, but they actually need help to make sure bills are paid. Then you may want to think about a convenience account. The thing to know about this is it's not the same as a joint account, which is what most of us are most familiar with. In a joint account, money is jointly owned, and the joint account holder automatically gets the money when you die. So oftentimes people set up joint accounts when managing money because that's what they're familiar with, but this can have unintended consequences. For example, say that my mother added me to a joint account because she wanted help managing her finances. Well, if she were to pass away, then the money would go to me, and she might have actually wanted that money split between me and my brother. Also, if I had gone into debt, then the creditors could come after her money in the joint account for that. So that's why we recommend a convenience account rather than a joint account, because with a convenience account, it does not change the ownership of the money. It only belongs to you, and it does not give your helper the right to keep the money when you die. So that is why we recommend the convenience account over the joint account in terms of those informal caregiving options. Now, in addition to these informal caregiving options, this publication covers the formal caregiving options. So if you know someone who needs more than just occasional help, it might be time to name a formal caregiver. And this piece discusses the formal caregiving options, and we actually have detailed guides on each of these as well, which I will go into in a minute, and I'll explain each of these formal caregiving options in a minute as we look at those guides. But first, I want to show you the next slide, please, which has information on choosing a financial caregiver. As I said early on, it's really important to make sure you choose the right person for a financial caregiver, or else it could lead to additional exploitation. So the guide gives some questions to ask to think about who is the right person. Like, do you trust them? Do you feel comfortable sharing your wishes? Is it someone who's going to carry out your wishes? And is it also someone who's organized, who will keep good records and keep their money apart from your money? And also, I mean, it's a time to think about the hard things. Like, is this someone who has an alcohol or drug or mental health issue that might cause problems in them managing your finances? So our guide, that Considering a Financial Caregiver guide, goes over all these questions to help guide a conversation with a client or a loved one who may be trying to decide who should they name. So now let's look at these managing someone else's money guides for financial caregivers. We have 4 guides for each of those formal caregiving options that we talked about, and they help people understand their duties if they're acting as an agent under a power of attorney, guardian, conservator, or any of the other fiduciaries. We'll go into those each in turn, but first I just want to look at the next slide, which just here is acknowledging how challenging financial caregiving can be. Now, those of you on this call who work in the field probably recognize that full well, but a lot of people don't have that exposure or experience and don't realize that, you know, even for financially savvy people, it can be hard to know where to get help with this type of thing. And also for other people, taking care of someone else's finances can be much more stressful than taking care of your own. There can be a greater sense of responsibility, and many people feel overwhelmed. So that's something to keep in mind as well, their state of mind, if they're acting as a financial caregiver or if they're getting help because now they need somebody to manage their finances, and they had always been financially savvy and able to do it themselves. So on the next slide, you'll see here's where you can find all of these managing someone else's money guides, consumerfinance.gov/MSEM. And they are designed especially for older adults and people, professionals like you that work with older adults. But they also, in case any of you also work with younger people with disabilities, they can also be helpful for that audience as well. So let's take a look at the guides. On the next slide, you'll see these are the 4 guides that we have. They help financial caregivers understand their duties. They include information on identifying benefits for the care recipients, describe warning signs of financial exploitation, and provide information on where to get help. So each of these formal caregiving options, as I call them, have a legal fiduciary duty. On the next slide, you'll see information about what is a fiduciary. Many of you may know this from your own work, but in case you don't, fiduciary is a legal term that basically means anyone who's legally named to manage money or property for someone else, or at least that's how we're using the term fiduciary in this context. And there are 4 main types of fiduciaries for managing money. There's a power of attorney, which is created by a legal document. There's a government fiduciary, which is created by the government agency, Social Security or Veterans Affairs. There's a guardianship or conservatorship that is named by a court. And then there's a trustee or a trust that can be named either in a legal document or in a court. So let's look at each of these. First, what's a power of attorney? This is the most common one that a lot of people have. Probably, hopefully, many of you on this call have a power of attorney form already lined up in case it's needed in the future. This is a legal document. Oftentimes people create them when they create their wills. And in it, someone known as a principal gives someone else legal authority to make decisions about their money or property. So it's important to know there's a healthcare power of attorney and then a financial power of attorney, and they're separate and you need both. One of them covers healthcare decisions, the other covers financial decisions. And oftentimes people will ask, oh, should I put, both my kids on both if they have them? Usually it's more recommended to have one on one and one on the other. But a lot of people ask, well, why should I get a power of attorney? Some things to know are that powers of attorney give you control to name who you want to manage your finances. If you don't do it and then become unable to manage finances, then the court will pick in guardianship. This can also make it easier for loved ones if you become unable to manage your finances suddenly, such as through a stroke or a car accident. So I do want to tell a story here just to give an example of why it can be important to have a power of attorney. Unfortunately, my grandmother, when she was in her 70s and in otherwise pretty good health, got hit by a truck and sent into a coma. And she did not have a power of attorney in place. So while she was in the coma, we had to go to court and get guardianship in order to pay her bills and to deal with everything else. And it was good to have that option, but it would have been a lot easier had the family just been able to pull out a power of attorney document and give that in order to move forward, rather than having doctors have to testify and go through a procedure to gain guardianship. So that's just a story to show the importance of these documents. On the next slide, you'll see what's a representative payee, what's a VA fiduciary. These are government fiduciaries who manage your government benefits. So Social Security will name somebody to manage a person's Social Security benefits. If they're not able to, that's called a representative payee. The VA calls it a VA fiduciary. The important thing to know about these government benefit fiduciaries is they only have authority to manage the benefits checks of the agency that made the appointment. So if the beneficiary has other money or property, the fiduciary has to have legal authority from another source to manage anything other than the government benefits. So they need to have a power of attorney or guardianship or something else. Otherwise, they're just managing those government benefits. And on the flip side, even if you're an agent under power of attorney or a trust, or if you're guardian or conservator, you don't necessarily have legal authority to manage the federal benefits check. So you have to be appointed representative payee or VA fiduciary for that. Some things to know is that, if you already are in one of those positions, then it's quite possible the government agency is going to look more favorably on you as the rep payee or VA fiduciary, because they know that person has already decided that you're somebody who they're comfortable with managing their finances. And a lot of people don't understand what these government fiduciaries do. So these are good guides for people to get to understand their duties and to explain them to other people if they need to hand them out to financial institutions or others when they are acting in the role. So let's turn to guardians. In some states, it's called a guardian. In some states, it's called a conservator. A guardian of property is someone who the court names to manage money or property of someone else who the court has found can no longer manage their finances alone. So these can be needed, like I said before, when an accident or sudden illness happens and the person has no power of attorney in place. Sometimes the guardian of the property is also appointed as guardian of the person. So that means the guardian can make healthcare and other personal decisions as well as financial decisions. So it's kind of similar to the power of attorney for finances versus the power of attorney for healthcare. There's the guardian of the person and the guardian of the finances. Now, the last type of fiduciary I want to talk about is a trust or a trustee. There can be trusts set up in court, but the ones that we're talking about in our guides are called revocable living trusts, and they're created through a legal document, a paper document. And basically, someone makes a revocable living trust to give someone else legal authority to make decisions about money or property in the trust if they can't make decisions themselves. So in the trust is the key part, because you can set aside just a certain amount of money, say $10,000, to be in trust to this person, or your car to be in trust to that person. So the trust also specifies who gets the money or property in the trust after the person who creates it dies. So that's another important distinction, is the trust lives on after death, as opposed to with the power of attorney, that authority ends upon death, and then the executor of the estate has the authority after that. So these are 4 different fiduciary options that may be useful to your clients and to others depending on their particular situation. So now let's go on to what are the duties of a fiduciary. If someone is in any one of these 4 roles, they have the duties of a fiduciary, and it's important they understand these duties, or else it can lead to exploitation of the individual, either inadvertently or advertently. So some duties are to first act in the person's best interest and avoid conflicts of interest. So we'll talk about that more in a minute. To manage the money and property carefully, that can include compiling an inventory of money, investing carefully, and finding out whether the person is eligible for other benefits from an employer or from the government. Keeping the money, the person's money, separate from your own money is also very key. And the guides discuss how to title bank accounts and how to sign checks on behalf of the person the fiduciary serves. And it's different depending which type of fiduciary the person is serving as. So I do encourage anyone dealing with this issue or helping somebody who's dealing with this issue to order the correct managing someone else's money guide and get that for guidance. It's also important to keep good records as a fiduciary. So let's look at these duties in a little more detail. This is the first one. Avoiding conflicts of interest can sound pretty straightforward, but think about it. In a fiduciary relationship, things can come up. Say you have a car from the person you're the caregiver for. Say you used that person. In our guide, we call the person that's being cared for Roberto. So I'll use that for this purpose. So say you use Roberto's money to buy a car, and you use it to drive him to appointments, but most of the time you drive the car for your own needs too. That would be a conflict of interest. And what about, say, doing business with family? Say Roberto needs repair work done in his apartment. So you hire your daughter and pay your daughter from Roberto's money to do the work. Even if your daughter is good at the work, it might be a conflict of interest. So it's very important to avoid these types of conflict of interest. Also, not to loan or give Roberto's money to yourself or to other people. Now, gifts may be allowed in certain circumstances, like say the person gave the same gift every year, like $50 to each grandchild or to each child or whatever it may be. That type of gift you may be allowed to still continue to give, or gifts to charity similarly. But it's important to first check with the court, government agency, or the terms of any legal document if you're acting as a fiduciary, to make sure you're still allowed to give that gift on behalf of the person. And very critical to get approval before paying yourself for your services. In some types of fiduciary relationships, it might be allowed, but it needs to be approved by the court, government agency, or in the legal document. So let's look at the second duty, managing money and property carefully. That also sounds pretty straightforward, but when you get into the details, you can see how it can trip people up. One important thing is to make a list of money, property, or debts, thinking about all sorts of things like cash, pension, retirement accounts, cars, jewelry, furniture, and other items of value. And then it's important to protect money and property. That can include putting valuable items in safes, changing locks on the property if necessary, and making sure things are insured if necessary. Paying bills on time and taxes. Taxes are a big thing that people sometimes forget when they're acting as a fiduciary, is the need to file taxes on the behalf of that individual. And the last thing is to check for benefits eligibility, especially if it is a lower income individual. And there's a great resource, benefitscheckup.org, that can help find out if the person's eligible for disability, Medicaid, housing assistance, food stamps, or more. Also, another great resource I want to mention is the Elder Care Locator. Hopefully some of you already know and use it, but it's available at eldercare.acl.gov. And from there, you can get all sorts of information about where to get food delivery, where to contact your area agency on aging, and more. Now, the third duty of a fiduciary is to keep money and property separate. And separate means separate. So that means never depositing the person's money into your own account or someone else's account. I've heard people ask about, well, what can they do in terms of, say they want to order groceries for themselves and the person they're the financial caregiver for. Can they do it all on one account to avoid a delivery charge? That type of thing. You can see how that even well-meaning people can, run into stumbling blocks and questions about how to keep things separate. It is best to truly keep things separate, separate purchases, separate line items, so you can keep the records. Avoid joint accounts unless they're already there. If there's a couple and they already have a joint account, you don't need to suddenly disband them. But for the reasons I was describing earlier about joint accounts versus convenience accounts, you don't want to just start setting up joint accounts for convenience purposes. And again, thinking about how to title the property and how to sign, you can get guidance in our Managing Someone Else's Money guides for that. So last duty I want to talk about is keeping good records. So that means keeping a detailed list of everything you receive or spend if you're acting as a fiduciary, keeping receipts, even for small expenses, and avoiding paying in cash because that can be harder to track and keep track of. And if you are acting as a guardian or something where there was a court fiduciary set up, then you're going to need to file reports with the court according to the schedule created by the court. So that record keeping can become even more important there. It can also become important in power of attorney cases where oftentimes, sadly, families fight over, oh, why is that person power of attorney? They're not managing the money right. I should be power of attorney. And so it's good to have the receipts to show that there was no mismanagement of the funds. So those are the 4 duties. Another thing to know about if someone is acting as a fiduciary is to look out for warning signs of financial exploitation. And our guides, our managing someone else's money guides, go over this as well, because that's another part of being a financial caregiver, is to look out for warning signs of exploitation. There might be subtle changes in behavior that are warning signs, like, well, it's not so subtle if someone suddenly tries to wire large amounts of money, but that's a red flag. More subtle might be if the person starts using the ATM more frequently, if they're not able to pay bills that are usually paid, if they stop getting their bank statements or bills at their house, maybe somebody else has rerouted it to them. If suddenly there are names on the bank accounts you don't recognize, or new or unusual gifts to a new best friend, those are all red flags to look out for. And on the next slide, you'll see some of the common scams. There's not only exploitation by people who know the individual, but all of these stranger scams that you've probably heard about. Oh, it looks like someone has started a poll. Do you want me to pause the presentation while you do the poll, or keep going?
Nope, you can keep going. They just need to write a quick answer in. Thank you.
Okay, great. Okay, so while you're writing your answer, I'll go over some of the examples of financial exploitation and some of the common scams. There's a grandparent scam, which is like when somebody calls and says, "Grandma, I'm stuck in another country. Wire money fast. Don't tell mom and dad. It's an emergency. I'm in jail," or "I just got in a car accident." And now with voice cloning and AI, they can make it even more realistic, which is even more worrisome. There are tax-related scams where imposters pretend to be from the IRS saying you owe back taxes. Imposters can also pretend to be from charities. And there are a whole variety of other phone scams. And you can get more information on these scams. And on the next slide, you'll see some more scams, investment scams and lottery sweepstakes scams. Death by family members, in-home caregivers, and someone who has a fiduciary relationship. Again, you can get more information on all of those at managing someone else's money. If you go to consumerfinance.gov/MSEM or to consumerfinance.gov/MoneySmart will actually get you to our Money Smart materials, which is another campaign that is our Money Smart for Older Adults curriculum with the FDIC, which I'll talk about at the end when I go over all of our resources. So let's go ahead and start talking about those resources. These are all free and available for bulk order at consumerfinance.gov/order. We have all of our publications in English and in Spanish. On the next slide, you'll see our Planning for Diminished Capacity and Illness publication. This is a good companion to the Considering a Financial Caregiver document that I talked about earlier. This is one that we worked with our partners at the Securities and Exchange Commission to create. And it's about planning for the future when someone's unable to manage their money or property. It also goes over trusted contacts. We recently updated it to include trusted contacts and to include something called Social Security Advanced Designation. So now you can designate up to 3 people who you would like to be your Social Security representative payee, should you need one in the future. So that's another good tool to know about. On the next slide, you'll see we also created an in-depth guide on choosing a trusted contact person. So if you know someone who's considering that trusted contact person route, that was one of the informal caregiving routes I talked about at the beginning. We have a whole advisory about that goes into more depth for more information on that. And on the next slide, you'll see our guide for preventing abuse of loved ones and financial abuse in long-term care communities. We know there are some slightly different concerns when a loved one or a client or someone you work with is in a nursing home or assisted living. And this has guides for recognizing exploitation in that context as well. And on the next slide, you'll see a guide about reporting elder financial abuse. So many people may see it, but not know where to report it. So this bifolds a quick reference guide that explains where and how to report elder financial abuse if you do see it. And next we have the Money Smart for Older Adults guide. This is the one that I just mentioned. This is our flagship program that we developed with FDIC, and it's specifically designed for people who work with older adults. It has over 2 hours of content on a lot of different scams targeting older people. The resource guide, which you see here, is in large print to be handed out to older adults and other individuals in the audience. There's also an instructor guide, which is perfect for people like you, professionals who may go out in the community and give presentations on how to avoid fraud and scams. The instructor guide gives you everything you need to do that, including a PowerPoint that's completely scripted. So you can use that, and I said it was 2 hours of content, but you're not going to want to talk for 2 hours. So it's designed so you can pick and choose those scams you may be seeing in your community. So maybe you're seeing a lot of tech support scams or identity theft or family emergency scams. You can pick those parts out of the guide and discover tips about them and use those portions of the PowerPoint for your presentation. And again, these are available in English and in Spanish, and there's no charge to you to order them. And all of our materials can be ordered at consumerfinance.gov/order. The last resource I want to mention are our fraud prevention handouts on this slide here. You will see originally we created these with Meals on Wheels designed to go out with meal delivery as an actual placemat that went under the meal with a scam prevention message for people to see. But then we found that all sorts of people were ordering them, not just as placemats, but as handouts, as posters. And so we have them on a whole bunch of different topics. We have romance scams, we have disaster preparedness, we have online safety and cybersecurity tips, we have the Social Security imposter. So these are nice ones to order and hand out in the community with just really quick, one-page, colorful designs to raise scam awareness. And if you do give presentations, either using Money Smart or otherwise, we also have some of these handouts that are word games, that are crossword puzzles or word finds. So those can be good things to have out sort of on the chairs for people to do as they come in early, as they're waiting. You can order these again for free and have them on hand if you do give presentations in the community. So the last slide here has our contact information. You can contact our office, the Office for Older Americans, at olderameriCans@cfpb.gov, or you can contact me directly at lisa.schifferle@cfpb.gov. And you can find all our materials at consumerfinance.gov/olderameriCans. The Managing Someone Else's Money guides, which are the ones on those 4 fiduciaries I talked about, as well as the Considering a Financial Caregiver. All of those, the quickest way to get to them is to go to consumerfinance.gov/MSEM, like Managing Someone Else's Money. So with that, I want to say thank you, and I hope that you'll take what you learned from this and use it in your work and use it in your communities to help other people to manage their finances when they become unable to do so. And I'm happy to take any questions there may be.
All right, Lisa, thank you so much for that presentation. I do have some questions that have come in. Are all of the resources that you shared or options that you shared to look after your finances available nationwide?
Yes. Yep. They're all available nationwide. There's some things like guardianship may be called conservatorship in some states, but it's the same concept. And I guess the one other sort of caveat is trusted contacts. They're available. They have to be provided now on investment accounts. For regular bank accounts, it's kind of up to the financial institution. More and more of them are offering them. Sometimes they call them emergency contacts or other things other than trusted contact. But yeah, you could try with your financial institution to get them, but they are available on investment accounts across the country, and all the other items should be available across the country as well.
And we're getting, what do you think is the largest or most frequent scam that you're seeing right now for older adults?
Well, if you look at the Federal Trade Commission's Consumer Sentinel data for 2023, which is the best compilation of data that we're seeing, the biggest is imposter scams, and that's of course a huge category that encompasses all sorts of things. Like they could be impersonating your bank, they could be impersonating your grandchild, they could be impersonating the federal government, like Social Security or the IRS. So that's a big category. Romance scams, we know, are a very high dollar loss across all age groups, especially older adults. And then tech support scams, while they're a lower dollar loss, are one of the most prevalent ones to affect older adults. That's where they say that you have a virus on your computer, and then they say they're either going to remote in or they want you to pay for a software package to fix them. But in fact, you don't really have any virus. They're just using it to get you either to pay them or allow access to your computer and your personal information.
All right. The next question that's came in is, do you have any recommendations for families whose loved one has not prepared for the inability to manage their money or access that money for placement needs? Anything they can do besides guardianship?
That's an excellent question. I mean, of course, it also depends on what their capacity is at the point. I'm assuming by the question that they're talking about somebody who no longer has capacity. If the person still has capacity, then you can sit down with them and have that hard conversation and talk about, power of attorney. Otherwise, guardianship is really the main route that you have left, is for the court to declare them unable to manage their finances and appoint someone, guardianship or conservatorship. I mean, you can check in your state too to see if there are other options, but that's the main one that I would know of for someone who no longer has capacity. If that's why it's so important to try to do it while people have capacity, and we know it can suddenly go from someone who can do a fair amount to someone who can't do anything, or even it can more gradually go, and then all of a sudden, it gets too far. So it's important to do while the person still has the capacity to do the, representative payee. Well, representative payee is actually another one that you can get, once you no longer have capacity. Social Security will appoint a representative payee and they'll decide, but you basically need some outside court-like body or government agency to deem the person unable to manage their finances and to name someone once you reach that point.
Excellent. So a question came in, how would you, or when would you advise starting that conversation with your clients that you're case managing about the importance of these documents? And what are some tips or tools that you can provide to a young professional in having that conversation?
Yeah, I think, the earlier the better is the answer. It's better to be prepared, because, sadly, anything can happen to any of us. I could go out on the street after this and get hit by a bus. So we don't know, even a young person, something tragic could happen. So it is important to have these in place earlier on. It can be harder for a younger person to want to do it because they may not have much, if you're in your 20s and have nothing, then it's probably not worth your, I can understand feeling it's not worth your money to hire a lawyer to get a will drawn up and to get a power of attorney drawn up. But, those of us who are middle-aged, although I hate that term, or older, it's probably time to start thinking about those things.
So I'm also getting lots of requests that they would love for you to come out and speak to their individual groups that they have. Is that something that you would be willing to do? And what is the best way to get in touch with you?
It's possible. I will have to see. We don't have a ton of capacity to go out in person, but if it's a large enough audience, we can. And if it's a smaller audience, we can sometimes do a more targeted virtual presentation to you. So you can contact me at lisa.schifferle@cfpb.gov and just say you are on this presentation and are interested in having a follow-up one, and tell me a little bit about who your audience is, where it would be in person, if you have virtual capabilities, and how big an audience you think it would be.
Next question comes back to the AI and how that's growing. Is the Consumer Protection Bureau, advocating for further legislation on trying to control AI in our country to watch out for older adults?
Well, I can't speak to what legislation we may or may not be advocating for, but I can say that we are looking very closely at this issue, as are other federal government agencies like the FTC and DOJ, and trying to figure out what the best solution is in order to protect American consumers. Because AI does have, it has good things too. Financial institutions and others can use it to help detect and stop scams. So we want to make sure the good uses of AI can still, come to light, while the bad uses are not allowed to run rampant with scammers.
And I just had another question. Could you review the warning signs that they can look for in their clients to see if they're being exploited financially?
Oh, sure. I mean, some things that I mentioned were like if they suddenly start making more ATM withdrawals than normal, if they suddenly start wiring money. I don't think it was actually written on any of the slides, but it was in my notes there. So, but if they start wiring money, going to the ATM a lot, if they suddenly have like a new friend or loved one that they either are signing over their will to or making a lot of gifts to, that could be a sign of, undue influence. Also, if there's a new person in their life that you feel like is not letting them talk for themselves or is, influencing their decisions, then that's another big red flag. And also looking for, in a position as a caseworker or a social worker, you may see physical abuse or neglect in addition to financial abuse or neglect. And you probably know they often go hand in hand. So where there is physical abuse or neglect, also looking for financial neglect and vice versa, are good things to keep in mind.
Another couple questions that this person believes that you can get a power of attorney and will forms at an office supply or even online to do it yourself. Is that something that you would recommend as a source if they cannot afford a legal attorney?
You can do that, but it's not something that we recommend. And we do recommend going to find an elder law attorney in your state to get them drawn up, to make sure they're drawn up properly, because it can be one of those like penny wise, pound foolish type decisions where you save money up front, but then when it comes to distributing your estate, maybe you find out the power of attorney was done wrong or the will was done wrong. So, yeah, it is good. Although I know that there are often healthcare power of attorney forms for free online, but less often financial power of attorney forms. So that's another thing to keep in mind, to make sure you have both if someone does go online for the free ones. And I see someone saying that legal aid clinics can help out some. I actually started my legal career at Maryland Legal Aid, so I like it when people shout out the legal aid people. We didn't really have that. We didn't have anything related to wills or powers of attorney when I was there, but there are other groups that may, or maybe they do now.
And then it says in Maryland, it takes 2 doctors to evaluate a person's competence. Then you petition to court to appoint a guardian. POAs can be durable or not. Is that true? Do you have any thoughts?
I don't know the Maryland law about how many doctors it takes to, to appoint a guardian, but that sounds right. That sounds pretty standard. That's similar to what happened to my grandmother in Arizona when we had to do it. They usually want more than one doctor because they don't want a doctor, faking things or fudging documents. So 2 at least is pretty standard. And then, sorry, what was the second part of the question? Something about power of attorney.
Power of attorney can be durable or not.
Yes, that is correct. It can be durable or not. Most people get a durable power of attorney, which is lasting from the time you make it, and then they just use it when they need it. Some people want what's called a springing power of attorney, where it comes into effect when a certain condition happens, like you're no longer able to manage your finances. That can be harder though, because then you often have to get an evaluation to show whether those conditions have been met. And we've also heard from financial institutions that they often, if they get a springing power of attorney as opposed to a durable power of attorney, they have to do more things to make sure it's a legit power of attorney that can be used. So that's why I think most people recommend the durable power of attorney, but you have to also trust the person who you're giving the power to, not to suddenly whip it out tomorrow and start trying to manage your finances when you're not ready for them to. So.
Right. Someone asked if you know of any resources of where you can find a list of attorneys that may take a sliding scale fee. I know we talked about legal aid, but are there other options for legal resources?
I don't know. There's the National Academy of Elder Law Attorneys, but they're not necessarily sliding scale. I would call the Maryland Senior Helpline or Maryland Legal Aid and ask them for referrals.
And I do know in Baltimore County, May 1st is Law Day, and we do have attorneys at all 20 of our Baltimore County senior centers that will meet individually and help people set up wills or power of attorney on that day for free. So that might be an option. Going in a different direction, the dating apps. How can you be safe in all of the scams going on? It has been on the news lately that there have been so many going on.
Yes, that's a great question. And it's not just on the dating apps. Sometimes it happens on Facebook or, other non-dating platforms where people then try to develop a relationship, or there's even the wrong number scam where people are texting you and saying, oh, oops, sorry, wrong number. But then they try to pretend to be someone and get to know you that way. So it's the dating apps and more. To be aware of when somebody's trying to develop these relationships. The main thing to know is to never send money to somebody who you haven't met in person, especially a new love interest, because that's what they're counting on, is developing this relationship online and then having the person send money.
All right, Lisa, do you have any closing remarks that you'd like to leave everyone with?
Just thank you all for having me, and thank you all for the work you're doing in the community, and feel free to look for more information at consumerfinance.gov/older-Americans.
We certainly do appreciate your time and all of the outstanding resources that you've shared with us that we can pass along to our network. Thank you, everyone. We will take a quick break and be back by 2:45. So you have 15 minutes to stretch your legs and grab a drink, and we will see you then. Thank you, Lisa. Appreciate
Thank
your
you.
time.
Have a good day.
You too. All right, as we head into our last presentation, we're going to start with just a fun activity. Recent research has given us insight into the importance of mobility and balance as we age. Mobility is one of the key things to healthy aging, and recently researchers found that the ability to balance can indicate longevity for older adults. Their report stated that people who failed a balance test of standing on one foot for 10 seconds are twice as likely to die within the next 10 years. So let's all take a second, get out of our chairs and stand up. And we're going to go ahead, shut our eyes, and on my say, you're going to lift one foot. You decide which one, and I'm going to count 10 seconds, and we'll see how many of us are able to maintain 10 seconds with our eyes shut and 1 foot off the ground. Ready? Go ahead, lift your foot. 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, go ahead and have a seat. And by a show of the heart emoji, how many of you were able to reach the 10-second mark without any trouble? Oh, there's a few hearts coming up. Now, when you consider that we have about how many people we have on our conference call, that's not a lot. Now, by the thumbs up, how many of you were able to maintain for 10 seconds, but you were pretty wobbly? A little more emojis are coming up. So while this is just a fun activity, and for us, it doesn't really have any indication for the 10 years like it would an older adult, we can work on our core and still rectify as older adults could as well. But it is an interesting way to think about it, where that problems with balance are the second leading cause of unintentional injury deaths worldwide, according to the World Health Organization, and more than 37 million falls are severe enough to require medical attention each year. Linda Horn is an assistant professor and the director of academic affairs at the University of Maryland, Baltimore School of Medicine, Department of Physical Therapy and Rehabilitation Science. She's an adjunct instructor for 17 years prior to becoming a full-time faculty member. She received a BS in physical therapy from the University of Maryland, Baltimore in 1984, Master of Health Science from the University of Indianapolis, Krannert School of Physical Therapy in 2003, and the Doctor of Science in Physical Therapy from the University of Maryland, Baltimore in 2007. She has 30 years plus of clinical experience in a variety of settings, including acute care, outpatient, and home care. She is also a board-certified geriatric and neurological specialist. She is active in the American Physical Therapy Association at both the state and national level. Research interests include balance and falls in adults, professional behavior and interprofessional education, and improving upper extremity function after a stroke. Today, Dr. Horn is going to define balance and other factors that can affect balance. She will outline the link between balance and function, as well as how these can be indicators of longevity. Lastly, evidence-based assessments and resources will be shared to aid clients' balance and fall risk. Welcome, Dr. Horn, to the Senior Solutions this afternoon.
Thank you so much. It is with pleasure that I address you today to talk about this topic that's not only pertinent to us in our professional roles, but is so crucial for our patients and for our clients' well-being, and that is balance. Today, we're going to explore about how achieving balance is not just a desirable pursuit, but is something that is fundamental when you look at longevity and for function. While I am full-time faculty, I still do a little bit of clinical work, and I do that at the Baltimore VA. And there we have a balance and mobility clinic, and that is for our older vets, 60 and older. So I'm trying to at least keep my hands still in this area for sure. So today what we're going to be talking about is we're going to talk about the components of balance, because it's not just as simple as balance and there's one way to evaluate it and one way to treat it. We're going to talk about that link between balance, function, and longevity. And you'll be able to identify appropriate assessments and tools that you can use with older adults. And these are going to be tools that are easy to use and tools that are easily accessible. And you'll also be able to identify some intervention strategies. We'll talk a little bit about intervention as well. So one of the things I did to prepare for this, just for fun, is I put the question in, what is the key to longevity and function in older adults, into ChatGPT, since everybody's doing it these days. And I'm like, I just wanted to see what it came up with. So it did not generate my entire presentation. It didn't generate much, but it really did kind of come up with a nice holistic view when I put that in. And so one of the things that is a component is regular exercise. I think we all know that. This helps maintain strength, range of motion, flexibility, endurance, balance, improves our overall health, can improve blood sugar, can improve blood pressure. So it has a lot of benefits. A healthy diet that supports health and vitality. And one of the things that's really important is hydration. And we know that many of our older adults do not stay hydrated. And so then that can lead to dizziness, can lead to falls. So there's a lot of interaction there. Maintaining social connections. When we look at the social connections, this helps combat loneliness and depression, which we know can be a problem in our older population. But it can also then help promote that emotional support, intellectual stimulation, which is another key component, and that sense of belonging. And while these may seem kind of remote from balance, they all do play into it, because these are the kind of factors that motivate individuals to want to do exercise or to want to get out and to participate in activities. Mental stimulation, things like reading, doing hobbies, doing puzzles, learning new skills, going to the senior centers and trying to take different classes, are all ways to help maintain and improve cognitive function. And they can also, the studies have shown, it prevents some cognitive decline as well. Sleep is critically important. Getting not just enough sleep, but also high quality sleep. And many of our older adults complain of that. When I was in the clinic, and even now, sometimes I'll have a patient come in and their balance isn't as good as it was the last time I saw them. And one of the first questions I ask them is, how did you sleep last night? And many times it may be a night that they didn't sleep well. It really does have an impact on physical function. Managing stress. Again, chronic stress has a negative impact on our bodies as well as our mental health. And so there's lots of other activities that we can incorporate with interventions for balance that can be very helpful, like meditation, mindfulness, breathing exercises, spending time in nature. There's been some work showing that that can be very helpful. And again, exercise. Exercise keeps coming out is one of those key factors. Avoiding harmful habits. Here we're talking about avoiding or not drinking too much alcohol, minimizing that, not smoking, not doing risky type behaviors, not having exposure to different toxins in the environment. Maintaining a sense of purpose. And some of these are kind of overlap, but having that sense of purpose, a sense of helps the well-being, overall well-being, but also helps, again, motivate that individual. I have things I want to do, I need to do, I want to do. And then adapting to change, which can always be a hard thing when we're talking about adapting to change. But this holistic approach that addresses all areas, physical, mental, emotional, and social well-being, is essential for promoting longevity and function in older adults, and balance is a piece of that. But ChatGPT did identify that regular exercise included balance exercises. A lot of times when we think about exercise, we think about strength and range of motion, but very specific balance exercises like standing on one foot can be part of the treatment plan. So why is balance so important? Well, we're going to talk a little bit about the science of balance, the balance function link. We're going to talk about longevity and assessments.
So we're going to talk just a little bit more about the science of balance. And here again, we've got the standing on one leg that's so important. But when we look at the definition of balance, what the definition is the ability to control the center of gravity, which is somewhere kind of in the middle of the body, over the base of support. In this case, it's one limb on the ground. It could be both limbs. It could be, if you're in a seated position, could be your feet and your bottom in a given environment. So this environment here on the sand is a very difficult environment. Somebody may be able to stand on one leg on a firm surface with no problems, but yet when they get on a surface where it's a little bit uneven and a little bit unsteady or not more compliant, then they have more difficulty. So we always have to think about the environment that the individual is functioning in. So when we look at balance, generally there is something that's happening that we have to respond to. So there's a change in the sensory input, and we're going to talk a little bit more about those in a minute. That information is processed centrally in the brain. From there, very quickly, the brain has to decide what's going on and what needs to happen so I don't fall over. And so we get this motor output that then creates a balance response. But this is a continuous cycle because once you make a response, there's additional sensory input that's going back into the system and needs to be reprocessed. So it's kind of not a one and done, it's just constantly going on. The three main sensory inputs are vision, the vestibular system or the inner ear system, and the somatosensory. And that's kind of what we feel through our feet or for whatever surface, whatever's touching the surface. With vision, it can be what I actually see or what is perceived. So if you can think about if you were standing at the corner and a bus goes by you really fast, sometimes you feel like you're moving, but you're really not. It's just that your visual world is moving. So that's kind of a perceived visual movement. The vestibular system is the inner ear, and this gives us information about where we are in respect to gravity and where our head and our neck are moving at that point in time. And then the somatosensory information, what we feel with what's on the ground, and many times it's our feet that are on the ground. This is going to give us information about where the joint position is of the ankle, as well as what is going on with the surface. Is it a firm surface? Is it compliant? Is it a rocky type surface? And so all that information is centrally processed. And so the brain very quickly has to decide, what are the sensory systems saying? Are they saying the same thing? Am I seeing, is it something that's a real visual change or is it perceived? Same with the somatosensory. Is it real or is it not? We kind of get those weird sensations that are inaccurate, like on a boat. The brain also has to process, what is the right side and the left side saying? Is it saying the same thing? And from there, then the brain very quickly decides what is the motor output. And with that motor output, there has to be adequate range, strength to create this motor output. And that motor output is going to be the different balance reactions. And we do categorize them, although for many activities, you'll see aspects of several different components of balance. And so it's not just necessarily, we can't always break it up very neatly, but for the purposes of learning, we do. So when we talk about static, really we're just talking about quiet standing. Nobody is truly static. We all have a little bit of sway, even though we may not be able to see it or we may not be able to feel it. But if I put everybody on a force plate, I would be able to see a tiny bit of movement. Sometimes that's called quiet standing or static. In the dynamic, what we're looking at is the ability of the individual to shift their weight over the base of support without losing their balance. And this can occur in different directions. It can occur side to side. There we go. It can occur forward, backwards, and even in some diagonal. And so we want patients to be able to shift their weight. And with our older adults, one thing that they really are uncomfortable with is shifting their weight forward and backward. And so sometimes in therapy, this becomes one of the exercises we do. And there's a variety of reasons. We're going to kind of talk about all these things that really contribute to balance. The other balance reactions, one is anticipatory. And with this, in this case, the individual is lifting their arms up voluntarily. And when somebody has a voluntary movement like this, we know from the research that the back muscles and the hamstrings and the back of the thigh, those muscles will fire first to stabilize the body so that you don't fall over when you lift your arms. And for some of our older adults, they have a really difficult time with that, so that if they lift their leg up to go onto a step, they start to lose their balance. It may also be some weakness and range of motion problems, but it may also be part of their anticipatory postural control is impaired. And then, of course, reactive. This is how we can test it. It's have somebody kind of almost do a trust test, and then we move our hands away and tell them, try to stay upright. But if we look at it, there's a very functional reason we want to look at reactive postural control and why we want to work on that. And that's because you can come around that corner and not know that there's somebody else coming around the corner right in front of you, and you can bump into each other. And hopefully, both of these individuals were able to regain their balance and nobody fell to the ground. So some of the keys to being able to have good balance, one is to have good strength. And, sometimes we don't think about that when we think about balance, that we also need to do strength training. We have to have adequate motion at our joints, particularly if we're standing around the ankles, because they tend to get very tight and then it makes it difficult to do that anterior and posterior weight shift. And then there also has to be adequate flexibility. And again, for many of us, things like our hamstrings are tight. And we generally can compensate for that until another problem comes along, like maybe somebody has a stroke or somebody has Parkinson's disease or somebody now has had a total hip or a total knee replacement. So now once there's another comorbidity, some of these problems that they have may now become more of a problem. And again, there's other balance considerations that we have to really think about, and these definitely impact balance. We know there's a correlation between cognitive status and balance problems. Individuals who have cognitive issues have worse balance. We can't look at balance without looking at polypharmacy. Again, many of our older adults are on different medications. More than 4 prescription medications is considered polypharmacy. How many of our older adults are on less than that? Very few of mine are. Most of the older adults I see have a laundry list of both prescription and over-the-counter drugs that they take. But it's also the type of medications that we also need to look at. There is something called Beers criteria, and I didn't add that into the references, but it's easy to look up. But what they do is every couple of years is they look at what are the potentially inappropriate medications for older adults. Now, this does not mean that they shouldn't be prescribed, because sometimes it is the best drug, but it is really is designed so that the prescribers are intentionally thinking about, does the individual need this drug? Do they need two in the same class? Or is there a different way that we can approach this problem? So one of the, there's a couple different categories here. One is the anti-seizure or the anticonvulsant medications. Now, for some patients, they absolutely need that for seizure control. But for some individuals, do they need to be on gabapentin and maybe some pain meds? Because the combination may be difficult. Some of your antidepressants are also, let's put that down. Some of the antidepressants as well are on the Beers criteria on the potentially inappropriate medications. Some of these include your tricyclic antidepressants and your selective serotonin reuptake inhibitors. Again, doesn't mean they shouldn't be used, but if this individual is starting to have falls, these medications need to be looked at. And any of us as professionals can say, you know, there may be a problem with your medications and you need to take all your medications and go to one physician and have them look at the whole thing as a package. The antipsychotic medications can also be a problem. Your benzodiazepines, because these produce sedation, they decrease anxiety, decrease muscle spasm, particularly when there's more than one on board. We know that from the literature that opioid use is one of the factors in falls. Again, there has to be a balance between pain control and the individual being able to function. But is that the best medication? Is there a different medication or a lower dose medication? Then, of course, the sedatives, and these are advertised all the time on TV. And we know older adults do tend to have some sleep issues. But when you see on TV, go talk to your physician about, you know, Lunesta, Sonata, and Ambien, they're going to go talk to them. And these drugs are very sedating. And if the individual has to get up at night because they're having some frequency with urination, then they're going to be quite groggy. And, you know, is this the best thing for them to do? Are there other sleep hygiene things that we can do so that they, if they have to get up in the middle of the night, they're not going to be all groggy? Or if the sedative really is something they need, can we rearrange their environment so that there is a bedside commode and a light that they can just tap to turn on? So all they have to do is hold onto the chair, stand up, and turn around, which could reduce their risk of falls. And then, of course, there's other types of medications as well. Other prescription medications they may be on, there may be some interaction. Many patients are on over-the-counter medications, and it's really good to find out what all they're on, as well as herbal supplements. All medications, if you look at medications, many of them, one of the side effects is dizziness. Dizziness is going to predispose somebody to falls and will make them feel off balance. Many of these drugs will make them sleepy. They may make them confused. They may cause blurred vision. And some of them may cause orthostatic hypotension. So when we look at some of the blood pressure medications, sometimes when patients go to the physician, of course, they have white coat syndrome, and there may need to be an adjustment of that medication because when they go home, maybe their blood pressure is not as high. Now they are on blood pressure medications. They go to stand up and they're really kind of woozy and may have some problems with that. Definitely the antihistamines this time of year. How many of us are taking some type of antihistamine for seasonal allergies? Those can be very sedating and can also be a risk factor for falls. And so we just need to look at those medications carefully. The other thing is vision, or I skip comorbidities. Let's talk about comorbidities. So individuals who have some type of musculoskeletal problem, they could have arthritis. They could have joint replacements. They could have a recent fracture or an old fracture that they still have some weakness from. Individuals could have neurological problems, multiple sclerosis, Parkinson's disease, stroke, and a variety of other neurological conditions that can definitely impact their balance. And then vision. You know, I always ask my patients whether or not they've been to the physician in the last year, to their eye doctor, because one of the things that they don't know is if they have glaucoma, because you generally don't feel anything with glaucoma, so they should be checked yearly for that. And anybody whose vision is less than 20/40 corrected may be at higher risk for falls and definitely needs to see their eye doctor, especially if they're like, well, my eyes seem okay, but it's been 5 years since I've gone. I really try to facilitate them going to the doctor. So I think we can see is that balance is multifactorial. And that's good because there's a lot of systems where there's some overlap with balance, so that if there's a problem in one system, individuals many times can compensate, or they can learn to compensate with therapy. And so one problem isn't going to just totally blow their balance. But the problem is that it makes it really hard to assess balance, because we can't just randomly treat and say, okay, I'm going to do single limb support with everybody, have them stand on one leg, because maybe that's not their problem. Maybe it's the sensory integration piece and being able to use their inner ear system well for balance. So we have to know what the problem is so that we know what to treat. So one of the things on the reference list is the CDC's STEADY program, and that's stopping elderly accidents, deaths, and injuries. They have a wide variety of resources that are free for you to print. Can't get many of them sent to you anymore. Most of them are downloadable and you can print them, or depending, maybe the family member or the client or patient themselves can also access this. And they have a really nice checklist just to look at fall risk, and of course, one of the big things is have they had a fall in the last year. Looks at certain medical conditions. Some of these different prescriptions we talked about could put them at high risk of falls. We're going to talk about all three of these tests. They're very quick and easy screening tests to do and really can be done by anybody. Here's the vision. And then also if they have orthostatic hypotension. So for patients who tell me, when they go from sit to stand, or from laying down to sitting, that they get really lightheaded, I'm going to do a check to see if their blood pressure decreases when they go from a change in those positions of more than 20 millimeters of mercury for the systolic, or 10 for the diastolic. And there may be other risk factors that that individual has. So this is just a nice, easy checklist to do. So one of the things that I think that we can see is that in order to function in almost any position, we need to have adequate balance. We need to have good balance. Sometimes we need better balance than others, right? So if we're running, we need balance. We also need other things, right? We need strength, we need range of motion, we need endurance. Well, we definitely need balance. If you're going to walk the tightrope at the Renaissance Festival, you need balance. Probably more there than walking. Walking's a great activity, by the way. And it doesn't matter the position. It could be also in sitting. And so individuals who are in wheelchairs, they also need to have good balance and good core strength. And depending on what their injury is, there may be different ways that we have to teach them to compensate. Dancing, golf. But what this comes down to is that we do know there's a link between longevity and balance and function. So you talked already about the single limb stance. I did not have that one in here today. I have a couple other ones. That's great. We're really covering a lot of different ideas. So this is a study that was done in Pittsburgh, University of Pittsburgh, by Stephanie Studensky. And they looked at walking speed, and they associated walking speed with mortality. And the bottom line on this is what they found is that older adults who walk faster than 0.8 meters per second, live longer. And that the faster you walk, the longer you live. Now, there's a lot of caveats, and you can't say just because somebody doesn't walk fast, they're not going to live longer, because there's a lot of other factors. If somebody has a disability, if they manage their disability, then certainly they may live longer. But we're going to play this just so you can hear these older adults talking, and you can kind of see the difference in their walking. It'll take a second for this to come on. It'll do a countdown.
I think I still have the spring in my step.
But on the whole, I'm probably not walking too differently from what I did before.
I'm going to ask you to walk at your usual pace, just as if you were walking down the street to the store. Are you ready? Begin.
For 73-year-old Janice Fields and 92-year-old Edward Gurjoy, taking this short walk may speak volumes to physicians when it comes to helping assess their longevity.
The reason that there's a relationship between walking speed and longevity is because your walking speed is a very simple reflection of how well many of your body systems are doing.
Dr. Stephanie Studensky from the University of Pittsburgh and co-authors evaluated data from almost 35,000 adults aged 65 and older, participating in 9 of the largest ongoing aging studies in the U.S. and worldwide. Baseline walking speed was analyzed along with a variety of other health factors, and participants were followed up to 20 years.
In every population, no matter how old they were, what sex they were, what kind of health conditions they had, that there was a strong relationship between walking speed and survival.
The study appears in this week's JAMA, Journal of the American Medical Association, and provides tables and figures estimating the probability of surviving another 10 years and also the median years of remaining life.
We can look at your age and go up to your walking speed, and this says you're going to be around for another 20 years.
Oh, well, thank you.
Your median life expectancy about 8 years.
8 years. I'll make it just to 100.
You're going to make it, well, that's just the median. You might beat that. This kind of information might be useful and valuable to the healthcare system, to doctors, families, and patients, in giving them a sense of their own vitality and longevity.
Catherine Dolph, the JAMA Report.
I love watching him walk at the end. He's got quite a step there. He really has good speed. And so with walking, all these individuals, we saw most of them without assistive devices, but some individuals, if they need assistive devices, they can actually walk faster and further. And so that can be really good. So the rolling walkers, the rollators, the ones with the wheels, sometimes that can be really helpful, and they can actually get better exercise, and it can actually improve their physical functioning. We've all heard that when we look at steps, that usually 10,000 steps is kind of the goal. And I strive to do that. And on some days I don't make it because I'm sitting at my computer doing work. But there was a systematic review that looked at and did a meta-analysis. It was of 15 different studies, and the mean age was 65 years old in this. So they looked at individuals over the age of 60, but the mean age, since they had some at 60 and some older, they looked across 15 different studies. And what they found is that lower mortality occurred somewhere between that 6,000 and 8,000 steps. So some people may say, I cannot get to 10,000 steps. Well, maybe if we go for a lower number, they would feel like they could actually do it. I also tell my patients that, you know what, we can start off with 1,000 or 100, whatever it is that you're doing, we'll just aim for a little bit more. Now, some of the devices that we use to count our steps may not be as accurate. They can be, the type of device can affect accuracy, as well as where they're wearing it, as well as walking speed. And I know with my Fitbit, when I was on a bus in a bumpy road last year, it was amazing how my step count went up. I was not walking. So you do have to, realize that it's just a guide. It's not going to be an absolute number of steps, but it certainly is a guide and can be a way to look at progress. Here's another test we're going to look at, the sitting rising test. This is one you can try after you're done today to see if you can actually sit down on the ground without using any points of control and rise. This study was done actually in 2002. It's been a while, but also Brito did some more work with it in 2012 as well. And there's a total of 10 points for this. And we'll see this in the video. So from stand to sit, if you can do it just like he's doing it on there without using your hands or putting your hands on your thighs, then you get 5 points. If you can stand up that way without touching anything, you get another 5 points. However, there's a deduction of 1 point every time you use your hand, the forearm, your knee, put your hands on the on your thighs, use the side of your leg. So I can go down. It's pretty well controlled. I got to work a little bit more on that. Coming up, I need to use one hand. So I get a 9 on this. And what they found is that if you can do the individuals who score less than 8 points, that was associated with a 2 to 5 times higher death rate. And this was looked at over 6 years. And what they found is that a 1 point increment was a reduction in 21% mortality. So that by able to improve this, it may be another marker for longevity. Now, again, not everybody's going to be able to do this. Some people have disabilities that don't allow it, but it's an interesting one to do. And for some higher level patients, I think this is a good test to do.
Welcome back to Therapy Thursday. Lately, I've been reading an excellent book. It's a few years old called Longevity, and I stumbled across a test that I was actually unfamiliar with. If you know Dave and I, you know we're fairly obsessed with longevity just generally. I'm going to do this test on Dave quickly with no cueing. He doesn't know what's going to happen here. So Dave, I'm going to have you cross your feet, and you can slowly try in one attempt to lower yourself to the ground without using your hands, your elbows, or putting your hands on your knees or hips. So try to lower yourself slowly to a seated position. Good. And now on a single attempt, you're going to try to reverse that. You're going to try to stand back up. Good. Okay. So Dave's going to live a long time. So that's actually scored a 10 out of 10. You get 5-point scale for coming down and 5 more points for standing back up. You add the two together for a cumulative score. Now, I wasn't surprised that Dave could do that as a very healthy 41-year-old person. But I was surprised at the statistics that have come out more recently on this test. It was originally published in 2012, and they just saw that when they followed people for about 6 years, there was 8% of the total study population of about 2,000 that actually died. And they could tell predictably who had a higher risk of dying based on their ability and the score on this test. Now, more recently in 2020, another study came out with way more people. And the thing that really took me aback when I looked at the data is only 8% of people over the age of 55 can actually do this test. And as we age, for every 1-point scale difference, by the way, you lose a point each time something touches the ground, and you lose a half point if you become unsteady, as judged by the observer during any part of the exercise. For every 1-point decrease, it ups your risk of dying by upwards of 21%. So despite the fact that I think this is a very broad test, there's probably healthy user bias, people that can do this probably exercise, et cetera, as a generic test, you should try it right now. If not, maybe you need to work on your strength, your hip mobility, your knee mobility. Maybe there's an injury that stops.
So this is definitely something that you could try on your own later on. And I think that even if our patients can't do this or it's not safe for them to try it without holding on, being able to get to the ground and off of the ground is another thing that we need to try with our patients. Most of our patients we can try this with. I want to, at least in therapy, one of our goals usually is that they can get on and off the floor. It may not be without using a chair or the sofa, but then we can instruct them that, if you were to fall and nothing hurts, that you can crawl over to the chair or maybe have a family member bring the chair and then instruct them how to get off the floor safely. So I think that that's another skill that, while it's not quite as high level as this, it's still a really important thing to be able to do. So the STEADY program has several different assessments, and the screening is really, there's some screening questions to see, is this individual at higher risk for falls? Then are we going to assess them to look for some of those things that are modifiable? And then there may be interventions that are necessary for that individual. And so I know this is busy. You can find this on the CDC website, but it's really just the algorithm that can be used by any professional to really help identify individuals that are at risk for falls. And anybody who's over the age of 65 should be screened by a health professional. And we likely don't know what was done at the doctor's office or at their other healthcare providers that they see. And so every patient I see, I'm going to at least ask them the screening questions. And we're going to talk about the screening questions. There's a couple different ways to do that. And then really, are they at risk or not at risk? And then what's the intervention potentially going to be? So there's a really easy screening that can be done. That's really just asking 3 questions. Do you feel unsteady when standing or walking? Do you worry about falling? And have you fallen in the past year? And if they had fallen in the past year, how many times did they fall? Were they injured? Kind of what were the circumstances about that? We know that fear of falling and falling are predictors of each other. So fear of falling is a predictor for falls. Having fallen is a predictor for fear of falling. If they say no to all those questions, so we're going to talk about yes in a minute, but if they say no to all those questions, they haven't had a fall, they feel steady, they're not worried about it, we can certainly educate them still about fall prevention and certainly about risky behaviors. You know, as we are in our 65, 70s, probably we shouldn't be climbing on those ladders. And for many of my patients, I'm like, don't use the step stools in the kitchen either, because that's not going to catch you. If there's a problem with things that are up higher, maybe you can work with a family member or somebody else to bring down the things that you need to a lower shelf so that you don't have to do this risky behavior. We know that vitamin D has been implicated as far as being part of the fall story when people fall. And so making sure that individuals are taking vitamin D if there's a vitamin D deficiency, or at least if that's been looked at. Generally, individuals, many of our older adults are on vitamin D supplements, and that may be with their calcium or in addition to. Community exercise, fall prevention classes, certainly referring them to community exercise classes if they want to do that. Some people would rather exercise alone, and then we can provide them maybe with some online types of activities, or maybe there's a home exercise program they can be given to use. But for some people, many people, having that social interaction and that accountability helps keep them going in these classes. Certainly the senior centers have a wide variety of different classes. And in the Baltimore County Department of Aging senior centers, they have fall prevention programs that are all evidence-based. All the programs that they have been shown to reduce fall risk, and many of them by 30% or so, so by a significant amount. So education is powerful. Education alone won't do it. We still have to get up and move. And then reassessing individuals yearly is another big component of fall risk. Just because you didn't fall this year doesn't mean that it couldn't happen next year. We hope it doesn't, but it could. So now if you ask them those 3 questions and they say yes to any of them, then they're at higher risk for falling, and we absolutely do want to do the assessment. So when we assess fall risk, there's a lot of different components we could do, and sometimes we don't have the time to do all of these. I'm going to talk in a minute about some really common assessments that you can do very quickly that'll give you a good sense of somebody's risk of falling. Certainly doing that medication review. And on the Steady website, there's also a whole component for pharmacy as well. Doing the home assessment. The CDC has a home safety checklist that if you're in the home, you could do with the patient or client, or you could give this to the patient or client and they could do it on their own. Doing an orthostatic blood pressure check to see does their blood pressure really drop significantly when they go from sitting, lying down to sitting or sitting to standing. Visual acuity. There are different ways that we can use some of the handheld charts to really screen for it. But if that person hasn't been to an eye doctor in a while, then we may want to send them or at least refer them. Looking at the feet and the footwear assessment. Individuals who have balance problems, many times there may be things going on with their feet. It could be bunions, it could be hammer toes, it could be wounds, it could be that they don't have good sensation due to peripheral neuropathy from diabetes. So a good foot assessment, looking for deformities, looking for wounds, looking for sensation, looking for mobility. We know that the big toe sometimes can get very rigid for some individuals with really no injury. And when we walk, we need that motion at the big toe to walk normally. So the question is, can we restore that or can we fix that? Vitamin D intake, what other comorbidities do they have? And what is their activity level? How much exercise are they getting? You know, how many minutes are they getting? Because we know from several studies and from the national guidelines that everybody should be getting 150 minutes of exercise a week. And that can really look daunting for individuals if you break it up 30 minutes over 5 days. But you know what? If that just looks to be too much, let's start with 5 minutes a day, 5 minutes twice a day, doing some kind of activity, whether it's walking, whether it's running, whether it's using some type of stationary bike, whatever it is. Could be water aerobics. However, individuals who are doing water aerobics also need to do some land activity, so they're getting that stress on the long bones, like on the long bones in the leg, so they don't develop osteoporosis. So the 3 common assessments I think that really do, and I use these in my practice all the time when we do community screenings. These are the 3 tests that we primarily do, and they don't take a lot of equipment and they don't take a lot of time. And the first one is the timed up and go. Then we'll talk about the 30-second chair stand test and the 4-stage balance test. On the CDC website, they have forms that you can record all of these measures on, as well as handouts on how to do them and the videos. So if you're training others to do them. So we're going to start with the timed up and go. For this one, you need a chair, preferably one with arms that you're going to put up against the wall. If there's no wall to put it up against, you can hold it so that it doesn't move for the individual. And you need a stopwatch. And generally then we're going to put tape on the floor that is 10 feet away from where they're sitting in the chair.
The timed up and go, or tug, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling.
Now, the one thing, it's not really necessary to make them put one foot in front of the other. I just have them sit in a chair and have them put their feet in the position that they would like to have them in. So more of a self-selected position. But if it takes them more than 12 seconds to do this test, then they're at higher risk for falling. Individuals with like Parkinson's disease, once you say go, you start that stopwatch. And for some of those patients, it's really hard for them to get out of the chair. But that's okay. We want to include that time because by identifying somebody who's at higher risk for falls, then we can get them the services that they need. Now, the 30-second chair stand, this is going to look at balance, but it's also going to look at strength, functional strength in the legs. And even for somebody who may not think they can do it, I'm still going to have them try it. This one they do without using their arms. So I'm going to do the test just like it says. And if they cannot do this in the 30 seconds, they're going to get a 0. I may then decide, okay, I want to see how many they can do holding onto the chair. But that's really not the test, but at least I can get a sense of what they can do.
The 30-second chair stand tests functional lower body strength. To administer this test, you'll need a chair with a straight back and a stopwatch. Place the rear legs of the chair against a wall so that it cannot slide backwards. Have your patient sit towards the front of the chair and fold her arms across her chest. Ask her to keep her feet flat on the floor and sit upright. She should try to stand up, keeping her arms folded across her chest without pushing off with her arms. When you say go, she should stand up all the way and then sit back down, doing this as quickly as she can until you say stop. Arms should remain folded across her chest throughout the test. Stand close enough so that you can catch the patient if she loses her balance. If the patient gets tired, she may rest, but let the time keep going. If she cannot stand even once, the test score is 0. Not being able to stand up from a chair without using one's arms to push up indicates a high risk for falls. Record the number of times the patient stood up in 30 seconds. If the patient is over halfway to a standing position at the end of 30 seconds, count it as a stand. Now, based on the age and sex of your patient, find their normal range on this chart. If your patient's score is below the norm for his or her age and gender, it indicates lower body weakness, a risk factor for falling. If the patient can't stand up even once without using her hands, allow her to push off using a hand on the chair. Be sure to document any adaptations. The test score is still 0 for purposes of comparing to normative standards, but this way her personal performance can be evaluated from one assessment to the next. I find this test is very helpful for monitoring the effects of strength training. It's also useful for motivating patients because they can see how much they improve by doing strengthening exercises on a regular basis.
So again, the foot position does not have to be with one in front of the other. You can let them self-select their foot position. The other thing I'll do too, if I'm going to have somebody work on this at home and I really want them to try it without using arms, is I will have them put a cushion, like a 2-inch or 3-inch cushion or pillow in the chair. And many times that's just enough that the individual now can do a sit to stand independently. If they can work in that shortened range, then we can start to bring them down so that the goal would be that they can stand from a standard height chair without using arms and without having the pillows in there.
The 30-second chair stand.
Sorry about that. And the final test that is commonly used and that can be really easy to do is this 4-stage balance test. And again, there's no special equipment needed other than the stopwatch. And we're going to just take a quick peek at this one.
The 4-stage balance test assesses static balance, which is an important part of postural stability. To perform the test, you only need a stopwatch. Tell your patient that you will show her 4 positions and would like her to try and stand in each position for 10 seconds. She can hold her arms out or move her body to keep her balance, but should not move her feet. For each position, describe and demonstrate it, and then stand next to her and hold her arm if needed to help her assume the correct foot position. When your patient is steady, you can let go. Say ready, begin, and begin timing. But you should stand close enough so that you can catch her if she loses her balance. After 10 seconds, say stop and record the time she was able to hold the position. If a patient can hold a position for 10 seconds without moving their feet or needing support, go on to the next position. If not, stop the test at this point. For the first position, the patient should stand with her feet side by side. For the second position, she should place one foot so it is touching the instep of the other foot. For the third position, she should place the heel of one foot in front of the other foot, touching the big toe. For the fourth and last position, have the patient stand on one foot. An older adult who cannot hold the tandem stance or either of the 2 prior stances for at least 10 seconds each is at increased risk of falling. Thank you for taking the time to learn these important tests of gait, strength, and balance. We hope that you'll use these tests along with the other information in the STEADY toolkit to determine whether your patient is at risk for falling. By doing this, you can reduce your patient's chances of falling and experiencing the devastating consequences that often result from falls.
And the CDC study was originally really designed for physicians to use, something quick for them to use in the office, but it's something that all professionals can use. So once we've done these tests and we decide that the individual is at higher risk of falling, then there needs to be some type of intervention. And that can be a wide variety of different things depending on what the needs of the patient are. The intervention plan needs to be individualized for that patient or that client. And follow-up is essential for some types of referrals in some cases. They may need physical therapy. So when their balance is impaired and they're having gait problems and maybe they're weak or having foot, we can also do foot and footwear exam. So a comprehensive fall risk screening or balance screening at that point, or not screening, but examination would be really warranted. It may be that they need to be referred to the physician or PA or nurse practitioner, somebody that can look at their medications. Also, they can all do foot and footwear exams. The physicians, PAs, nurses, nurse practitioners can really look at the vitamin D, look at comorbidities, and provide that level of care as needed. And they may need a referral to the ophthalmologist or the optometrist for vision to have a screen, or because there are some vision impairments. The National Institute of Aging, the NIA, that's also on the reference list, is also a really good place to look for some different things about activity and balance. Certainly having exercise routines that include endurance activities, flexibility, balance, and strength are all important. Patients don't need to do all these exercises every day. Generally, the recommendation is to walk every day and then to have endurance, flexibility, balance, and strength activities 2 to 3 times a week, and they can be on different days. The physical activity guidelines for Americans, that's where this 150 minutes a week comes from, with 30 minutes a day, 5 days a week. But as I said, any movement will help if somebody can't meet this goal. And if that seems overwhelming, let's break it down, and so that they can have different goals to get up to this. This is on the CDC's physical activity page. So as I said, a lot of free information that's out there that we can all use. It's part of our tax dollars at work. And also from here, there's some of the different examples of physical activity. We want to find things that individuals find enjoyable, because if they do, then they're going to continue doing them. Could be walking, dancing, swimming, doing water aerobics, any kind of aerobic activities, bike riding, even yard work and gardening count as activity. Sports like tennis or basketball, and they need to update this and put in pickleball. Of course, then we may have other injuries that we need to look at as well. Individuals, when they're walking, is part of their golf game. And then, of course, different strengthening activities as well. So it's important to have a nice, well-rounded exercise program that addresses all these areas. And so I did include a variety of different references. The CDC, here's their website, NIA's website, and then also more for the STEADY website. And at this point, I'd like to open it up to any questions you may have. And I can't see any of it, so you will have to tell them to me. I can't see the chat box.
Of course, I'm happy to. The first question that came in was, is there a connection between later stages of dementia and falls?
Yeah, there is definitely with that. And sometimes it has to do because with later stages of dementia, those individuals can't really regulate what is safe behavior. So sometimes individuals with dementia will walk too fast or do activities that are risky. So we do see that. And then if somebody is not very active, particularly as their dementia progresses, then what we see is that their balance can be significantly impaired. So we do see that the later stages can be problematic.
All right. The next question I have is, are you screening for normal pressure hydrocephalus? Is there balance mobility improvement following treatment?
So for normal pressure hydrocephalus, we're really kind of looking for that constellation of symptoms, right? We're looking for that individual who now has a new onset of confusion, who maybe has incontinence, and who also has mobility issues. If I see that, yes, then I'm definitely going to send them, refer them to neurology to have that looked at. And yes, when these individuals are treated, many times I will see improvement in that. Part of the improvement, they still might need an assisted device, but that can also help them improve their functional mobility, improve their balance, and hopefully we can maybe progress them off of that. But yes, with treatment, I do see changes. And medical treatment, not just my treatment.
If you were to recommend 3 exercises for clients for improving balance, what would they be?
One of them would be doing the chair stands. Another one would be standing on one leg, because you can practice that at the sink, like when you're brushing your teeth or when you're washing dishes or whatever, you can practice doing that. It's also a safe place to do it because you can hold on to the counter. And the other thing I would say is to walk, doing walking activities.
And if people are utilizing a cane but still able to walk fast, does that still indicate their longevity?
The study did not really talk about the use of assisted devices, really the speed. So yeah, if somebody has to use a cane and they still can walk fairly fast, they should be in pretty good shape for that.
Excellent. I'm sorry, I'm having echo in my voices. I can't get it to stop. I apologize. For those that are still in the conference call, there are surveys up. You can do that while we're continuing our questions. You said sleep was a good indicator of balance. Are there tips or tools that you can provide for clients to improve their sleep quality?
That's a tough one. I do talk to my clients about, making sure that they do good sleep hygiene. So turning off not looking at your phone or the iPad or whatever you're looking at or the TV for at least an hour before bed, making sure you're not falling asleep with the TV on, making sure that those screens are all turned off or turned over at least, because that type of light is going to interfere with sleep. Now, for some of our patients, of course, they need to have a night light, but the night light really should be a separate light because that's not going to have the same kind of interference with sleep. Not having any caffeinated drinks, and they have to kind of see when that works. Is that after lunchtime? Is that after dinner time? So they kind of have to play with that. Also, for some individuals, um, making sure that they are staying hydrated, but maybe not having a lot of water or other drinks, maybe after a certain time at night. And again, they kind of have to play with that time so that they don't have to get up and go to the bathroom so many times. That can also be helpful. Teaching them some things with mindfulness. The other thing that personally I have found is that there are apps. I turn my phone over when I do this, but with the different types of noise: green noise, pink noise, brown noise, white noise. And the one I have found that works for me is brown noise. And there's free apps for that. And sometimes that can be helpful too. And if somebody's really having a hard time, then it may be that they need to see a sleep specialist.
The next question is in regard to the one test where you are standing, you're sitting cross-legged on the floor and getting back up to stand. Is that a reasonable test for older adults?
It is for some older adults, not for all older adults. For somebody who has a lot of comorbidities and a lot of weakness, maybe arthritis, that's significantly restricting their joint motion, no, that won't be. For those individuals, though, I still want to see, can we get down on the floor using a chair or the sofa, and can we get up? Because if they wind up in a situation where they are on the floor, if they're not hurt, then they can get themselves up. If not, then we have to have other strategies, such as making sure they have a cell phone on them. I think Maryland now has a new system where they will call individuals every day, like a lifeline system.
Yes, the Maryland Department of Aging does have that. Do you have recommendations for vitamin D intake for helping with balance?
So I can't prescribe. So I'm only going to look at, do they have vitamin D on board? Are they taking it? If somebody asks about it, I'm going to have to refer them to somebody who can give them medication recommendations. Their physician, the nurse practitioner, the pharmacist can't prescribe, their PA, those type of things. So, and it's going to depend. They're going to probably have to do blood work to make sure that they're giving them the right amount, because that's a fat soluble vitamin. So having too much of it's not necessarily better. So that's a balance. And so I would defer to their physician for that.
In closing, do you have 3 tips that you can give our case managers to share with their clients?
The big thing, I think, is to stay active in whatever way they need to walk, to keep their mind active as well, with whether it's doing puzzles or getting together with people so that they're not socially isolated, and exercising, doing some specific balance exercises, easy ones like standing on one leg, can be really helpful. And they can do that safely in the home.
One last question that came in. Do you have a sleep specialist that you would recommend for a client with dementia?
I don't have one in particular. If I have, what I usually do, it depends. At the VA, I have access to pretty much everything. So that's a very different situation, one that I do enjoy. But otherwise, when I am in the community, what I'll do then is look to see who's got those kind of programs. I think those kind of programs, when you're talking about sleep problems with someone with dementia, you're going to look to your bigger universities, such as Hopkins and University of Maryland. There, you're going to find those specialists. It's going to be harder in the rural areas, but now with telehealth, we may be able to hook them up with some of the ones at the bigger institutions so that they can get that specialized care.
Thank you so much, Dr. Horn, for being a part of our conference. This was an exceptional presentation.
You're very welcome. I enjoyed it. I wish we could be in person, but I'm glad we could get to more people this way.
It's wonderful information. I hope each of you had an enjoyable day and are leaving with tools to support your clients and patients in matters of balance for optimal aging. If you've registered for a second afternoon of training next week, you'll be receiving the link early next week for that training. We'll talk about fall prevention, advancing equity and service delivery to older adults, and nutrition's connection to balance. Once again, I want to thank our incredible speakers for day one of Senior Solutions. Baltimore County thanks you for joining our conference today as we strengthen the lives of older adults we serve through resources. The link to the survey is in the chat, and we'll look forward to getting your results. It will remain active for 1 hour. Have a wonderful evening, everyone.